Hello everyone, I'm Dr. Mahalakshmi, your faculty for forensic medicine with Medico. I think we all know why we are today here. So NEET PG has been postponed and there are multiple ways to look at it. There are people who will look at this as a difficulty and there will be people who will look at this as an opportunity. But however and the way you are looking at, what I would say is don't get too comfortable. Keep up the speed that you are going with and get into the final dash and we'll finish this with a good score. So we will start doing the questions and we will do the most important topics in the forensic now. So first, a child presents to emergency with complaints of severe abdominal pain and vomiting. The parents, they gave a history of child ingesting 10 to 20 ferrous sulfate tablets. So this is a case of iron toxicity. So the question is, which of the following can be used in the management of this condition? So for iron toxicity, the chelating agent that we use is, the answer is desferoxamide, right? So we will see a bit about iron toxicity and about all the chelating agents. So first, coming to the iron toxicity. This iron toxicity, this is commonly seen with children because of the bright color of the syrup and the tablets. They might accidentally consume this, and there will be stages seen in this iron toxicity. There will be 5 stages, and the first stage is that first they will come with vomiting. They will come with vomiting and pain abdomen. This is how they'll be presenting. And in the second stage, what will happen is that there will be false sense of wellness. There will be false sense of wellness. And if we leave them like that, what will happen is that they will suddenly go into shock. There will be profound shock. And they might even proceed to comatose condition, they might even proceed to. So finally, if they recover after all these, the final stage, they will be presenting with the strictures because of the mucosal injury in the esophagus and the stomach. They will be presenting with strictures. So these are the 5 stages of iron toxicity that usually we will be seeing, and the management is, we will be giving them mainly desferoxamide. We will be giving them desferoxamide. And this desferoxamide, it can be given in all routes of administration. Mostly oral is given. And while giving this desferoxamide in the patients, we will get to see something called Winrose urine. This is your Winrose urine. So what happens is that when you administer this desferoxamide, if there is excess iron in the body, these iron and the desferoxamide, they will combine and they will come out as these Winrose color urine. And as the level of the iron decreases in the serum, the color will also decrease, and finally you will be getting these clear urine. Like, just by getting this clear urine means that the iron toxicity is gone. No, not like that. Like, even if there is minimal amount of iron left in the body, you will be getting clear urine. Like, this is not a diagnostic thing, but still you will be getting this Winrose urine, and they might be asking this Winrose urine you will be getting in which toxicity. So this is one of the thing in iron toxicity. So next is your chelating agents we will be seeing. Chelating agents, the main mechanism of action is that they have 2 sulfhydryl groups. So all the heavy metals, they exert toxicity by attaching to these sulfhydryl groups in the body enzymes. So these chelating agents, they have these 2 sulfhydryl groups, and all the heavy metals, they will come and attach. The heavy metals, they will come and attach to these sulfhydryl groups, thereby exerting the antidote action. So this is the mechanism of action behind giving chelating agents in case of heavy metal poisoning. And few important chelating agents we will see. So first is penicillamine. So penicillamine we will be giving them in copper. So penicillamine is given in copper toxicity. Apart from that, you can give them in lead and mercury also. So, penicillamine you can remember by CML. CML, mainly copper, then mercury, then finally lead. So, these are the indications for penicillamine. Next is your EDTA. Second is your EDTA. EDTA is exclusively given for lead. It is exclusively given for lead toxicity, and there are certain contraindications for EDTA. So, if it is a lead toxicity, you will definitely give EDTA, and there are certain cases where you should not give EDTA. That is H and R. HR, heart and renal failure, like anuria conditions, all those heart and liver failure, you should not give EDTA. Those are the contraindications. In chelating agents, these are the main thing that you need to know. What are the indications? What are the contraindications? That much you have to remember. So, third is your dimercaprol, otherwise known as BAL. So, this BAL, it is mainly given for man, ball for man. So, that is mercury, arsenic and lead. So, this is your indication for BAL, and it is contraindicated in IOC, that is iron, organic mercury and cadmium poisoning, right? So, these are the contraindications for these BAL. And mode of administration, here the one important thing that we need to know is that this BAL, it is a viscous liquid. It is a heavily viscous liquid, and because of that only IM is given. IV it is not usually advised. So, there was some difficulty in administering this. Because of that, they made certain analogues of BAL. So, there were some analogues. So, those analogues are, which are those analogues? It is DMSA and DMPA or succimer. These are the analogues of BAL, and these analogues, they can be given in organic mercury. Organic mercury, they can be given. So, these are the important things related to the chelating agents. Apart from that, in the general principles of decontamination, we have to know about gastric lavage. So, gastric lavage, it is usually, we have to know the contraindication and the indication. When it is indicated? It is indicated when there is large amount of ingestion of poison. Okay, large amount of poison has been ingested, and when they present yearly. So, when they present yearly. So, these are the main indications for doing gastric lavage. And what you will be using for doing gastric lavage is Ewald's tube. You will be using Ewald's tube. And the main contraindication, you have absolute contraindication, that is in where? Where will you not use? It is for, yes, it is for corrosives. It is for corrosives and sharp objects. These two you will not definitely use, and there are certain relative contraindications. Those relative contraindication, that is your hemorrhage conditions. Then, which all conditions? Varices, right? It is in varices we will be not using. Then, if there is possibility of convulsion and if there is coma, all those are relative contraindications for gastric lavage. So, these are the main things that we need to know in gastric lavage. And there is one more thing, like in all corrosives, it is usually contraindicated, but there is one corrosive we will still be doing gastric lavage, and that is what? The exception is what? The main exception that we need to know here is what? It is, yes, it is your phenol. Carbolic acid, you can still do gastric lavage. Apart from that, oxalic acid also we can do gastric lavage. So these are the main indications and contraindications for gastric lavage. Then finally, we will be seeing about activated charcoal. The main mechanism of action by which activated charcoal decontaminates, it's by what? It is by, right, it is by adsorption. It is by adsorption. So this activated charcoal, gastric lavage and chelating agents, these are the main things that we need to remember in the general principles of decontamination. Clear? Shall we move forward? Okay. So the next question, identify the cause of following appearance in palms. And what they have given in the palms? It is hyperkeratosis, right? There is hyperkeratosis, hyperpigmentation in the palms. And this is something seen where? Where do you see this hyperpigmentation? It is seen with which poisoning? The options are chronic copper poisoning, long-term ingestion of arsenic water, application of mercury ointment, application of calotropis. The answer is here, the answer is what? It is arsenic water. Okay, long-term ingestion of arsenic water is the correct answer for this. And this heavy metal poisons you definitely have to remember for your exam. Do not go to exam without knowing about these heavy metal poisons. So heavy metal poisons, first we will be seeing about arsenic. All the points that is related to arsenic you can remember by this term black rope car. So all the things that is need to know here we will be seeing. So arsenic mainly it is the inorganic salt. Inorganic salt that is poisonous. That is your trioxide. That is the poisonous thing. And there is one more thing called acine. This is in gas form. That is the most poisonous. That is the most poisonous arsenic compound. And the inorganic salt, they are more toxic than the organic salt. And the main thing that we need to remember, apart from the usual things that we need to remember, is that it is a potent carcinogen. It is a potent carcinogen and it can cause lung, skin cancer. Clear? So it can cause cancer of lung and skin, and it can resemble measles, Guillain-Barré syndrome, all those diseases, pathological conditions it can resemble. And one more thing in the diagnosis that we need to remember is that, like, even in the ashes it can be found. It can be found even in the ashes, in the body where arsenic has been given. So this thing that we need to remember important here. And in the postmortem, the main thing that we will be seeing is red velvet mucosa. We will be seeing red velvet mucosa, rigor prolonged, and putrefaction resistance. That arsenic, it can be discovered in the body even after long time has been passed. Even if the body has been buried for a long time, we will be still able to identify arsenic from the body. So these things that we mainly need to remember in the post-mortem features. Apart from that, you will also have to know that peripheral neuropathy. Peripheral neuropathy is also seen. Peripheral neuropathy is also seen. And in the kidney, you will be getting PCT necrosis. You will be getting PCT necrosis in the kidney. So these are the main things that we need to remember in the arsenic. So this is the hyperkeratosis. Hyperkeratosis. keratosis. This is your raindrop pigmentation. Raindrop pigmentation. And this thing that we see in the nail, this white bands, this is your aldrich mees line. That is our aldrich mees line. So these are the main things that we need to remember in the arsenic. Next is your lead. So lead poisoning, here you can remember by this A, B, C, D, E, F, G, H, I. So first for A you have anemia. So anemia, the enzymes also we need to know. What are the enzymes that is getting inhibited by the lead? So first is your ALA dehydratase. ALA dehydratase. Sometimes they will give you ALA synthase. Okay, do not forget it is ALA dehydratase. Then second is your ferrochelatase. These two they have repeatedly asked these ALA dehydratase and ferrochelatase. And finally this coproporphyrinogen oxidase. All these three are the enzymes inhibited by the lead. So this is the first thing that you will be seeing in lead. Then secondly you will be seeing basophilic stippling. Basophilic stippling and Buttonian line. You will also be seeing Buttonian lines on the gums. Clear? Then thirdly, what you will be seeing is the colic. It is a colic pain. That is a very prominent manifestation in the lead. Colic pain will also be seen. Then D, drops, wrist and foot drops we will be seeing. Then we will also be getting edema. Cerebral edema we will be getting. Then G for gout. We will be getting saturnine gout. Saturnine gout. Then there will be hypertension. There will be hypertension. Then finally you will be getting infertility and impotence. So all these things you will be seeing in lead toxicity. Clear? So this is your basophilic stippling. And these transverse bands that you are seeing, what is this? This is your bone lines. Okay, lead lines on bone. And the site of deposition of lead, that is important here. The site is beneath the metaphysis. Okay, beneath the metaphysis you will be getting this lead deposition, that is known as lead line. And this is deposition of lead in the gums, your Buttonian line. And this is due to formation of which compound? That is plum sulfide. Okay, lead sulfide you will be getting. Okay, so what happens is that the lead, it will go deposit in the gums. In the gums the lead will get deposit and there will be leftover food, and from that leftover food there will be production of hydrogen sulfide. These hydrogen sulfide and lead, they will combine to form this lead sulfide, which will give this typical appearance in the gums. This is a very important thing that you will be seeing in lead toxicity, and this is due to neuropathy. You will be seeing foot and wrist drops. So these things you will be seeing in lead toxicity. And then finally mercury. Mercury, you can remember everything by the term table. So first thing that you will be getting is tremor. This tremor, they are also known as Danbury tremors or blower shake. So these tremors are also known as these, and this is mainly seen in occupational hazard. It is usually seen as a occupational hazard, and it can be either resting or intentional tremor. Initially it will start as a resting tremor, and later on it will become more coarse and it is known as intentional tremors, and they will become much more, like they will not be able to do any work. Okay, so the tremors will become much more severe. So these are the main thing in the tremor of mercury poisoning. And second thing, you will be getting acrodynia. This is also known as pink disease. What happens here is that, like initially, before like lot of years, what they used to do is that they will give this mercury compound in the teething powder to soothe the pain to the baby. They were using this in the teething powder, and because of that mercury in the teething powder, children develop hypersensitivity and they started manifested these features. So these features, what they get is that there will be lot of peace. They were getting paresthesia, pink, puffy, painful. They were getting all these features in their limbs. So this is your otherwise known as pink disease. And then you will be getting blue line on the gums. Blue line on gums. Then fourth, you will be getting mercuria lentis. So fourth, you will be getting mercuria lentis. So here what happens is that the mercury, it will go get deposited in the anterior lens capsule. It will get deposited in the anterior lens capsule. And there is one name reflex, like how we see the mercury deposit, it is known as brown reflex. It is known as brown reflex. So because of this deposition, they will be having this difficulty. It is known as mercuria lentis. And finally, erythism. And this erythism, it is also known as Mad Hatter's disease. Mad Hatter's disease. So what happens here is that you will mainly get neuropsychiatric manifestation. There will be anorexia, neuropsychiatric manifestation, hallucination. All these things will be seen in this erythism. So these are the main things that you will be getting in the mercurial toxicity, and all these things, they are mainly attributed to the inorganic mercury, mainly to the inorganic mercury. In contrast to the arsenic, here in the mercury, the organic salts, they are more poisonous than the inorganic salts. It is the organic salts, they are more poisonous. And the triad of mercury poison is that we can remember by the term GET. So it is gingivostomatitis, erythism, then finally tremors. So these are the triad of mercurial poisoning, and the stable, what we saw, these are the features of inorganic mercury toxicity. And you will be getting to see this. So this is your acute toxicity. You will be getting these rashes. This is the Mad Hatter syndrome. That is erythism, right? Mad Hatter is erythism. And these pink, peeling, puffy hands, this is your pink disease. So these are the features of inorganic salts. Now, this is what? Here. Do you see this? This one. This is the brown reflex. This is the brown reflex. That is what? Mercuria lentis. And this is the line on gums. This is the line on gums that we are seeing here. Now, this thing, what we see here is Hunter-Russell syndrome. Hunter-Russell syndrome. This is mainly seen with organic mercury. This organic mercury. So, this is also known as Minimata disease. Also known as Minimata disease, because it was initially found in the Minamata Bay. So, what happened was that there was one industry known as Chizo industry. They used to, like all the effluents from the industry, it used to be added to the bay nearby, that Minamata Bay. So what happened is that from that sea body, all the planktons, fishes, they all consume this mercury, and the organic mercury, it was transferred to the animals and the people who are consuming all those animal products. And what happened was that people, they started to exhibit all this erythism like feature. They started having, like especially children, they started having these MR, CP like feature, and they had chorea, all these things. They were started with this and resulting in plegia, like paraplegia and all they were getting. So what happened was that when they all came to the doctors, they found it as an epidemic in that region, and they found that it is all due to the Chiso factory, and the main culprit here is the organic mercury that is getting mixed in the seawater. So it is also known as Hunter-Russell syndrome. So inorganic, we saw the table. Here in the organic mercury, the main thing that you will be getting is Hunter-Russell syndrome. It is mainly neurological manifestation, and this organic mercury, it is much more poisonous than the inorganic mercury salt. So these are the main things, the main three heavy metals. Apart from that, there are few more heavy metals, and amongst them we need to know thallium, cadmium, copper. So copper, it is mainly used as a fungicide. So in the vineyards, they used to use this to spray the vineyards. They used to use the copper, and when the people, they are inhaling that copper, they will develop something known as vineyard's lung. They will develop vineyard's lung. That is mainly due to the diffuse alveolar hemorrhage that they will be getting in the lung. So this thing we need to know. Then secondly, you will be getting bluish green vomiters. Bluish green vomiters in case of copper poisoning, and there will be discoloration of hair. Discoloration of the same bluish discoloration of hair will be seen. And when these copper, they get deposited in the eyes, we will get to see something called chalcosis lentis. This is deposition of copper in the eyes. You will be getting uveitis and all. So this is chalcosis lentis. All these things we need to remember in copper. And the main cause of death in copper toxicity is renal failure. You will be getting renal failure. That is the main mode of death. Then thallium, here what we need to know in thallium is that, like all the features, it resembles arsenic. It resembles arsenic. All the features of arsenic you will be getting in thallium also. as I was saying, thallium, all the features, it will resemble more like arsenic. Like sometimes they will give picture of arsenic and there will be one or two points that you will be using to differentiate from thallium. So the main thing in thallium is that there will be alopecia. The first thing you will be noting is alopecia. Like in arsenic also there will be alopecia, but this alopecia, it is like mostly seen in thallium than arsenic. And second thing is that there will be madarosis. There will be loss of lateral part of the eyebrows. These two, they are mainly seen in thallium. And the triad of thallium, it consists of, so first thing would be alopecia. Second thing, abdominal pain. There will be abdominal pain. And thirdly, there will be neurological manifestation. Neurological manifestation. So these are the main triad that you will be seeing in thallium. And the thallium main point that you can use to differentiate from arsenic is that alopecia and madarosis. And like arsenic, it can also be found in ashes. Even in the ashes, thallium can be found. So in thallium, these things you need to remember. Then finally, we have the cadmium. So cadmium here, what you need to know is that the first thing that you have to remember is ouch ouch disease. So it is ouch ouch disease, otherwise known as ita ita disease. Ita ita disease. This is the main manifestation that you will be seeing in cadmium. Then finally in antimony. Antimony, what you will be getting is that there will be orange discoloration. Orange hypostasis. There will be orange hypostasis. And also mummification is favored. There will be favoring of mummification. So these are the main two things that we need to remember in antimony. So in the heavy metal poisoning, one more concept we need to know, that is metal fume fever. So what happens is that it is also known as Monday morning fever. Monday morning fever. So like people, when the people they are used to working in the industry where these heavy metals have been handled, what they will develop is that they will develop some flu-like symptoms. They will develop some flu-like symptoms and they will say that we are sick and we don't want to come to for work. So that is how they will say. But once they take the leave, the next day they will become all right. And people used to think that they are malingering. So that is why this Monday morning fever term came to be. So what exactly happens here is that like there will be inhalation of these metal fumes. There will be inhalation of metal fumes. Inhalation of metal fumes, and they will have these flu-like symptoms, like they will have fever, myalgia, nausea, all these symptoms they will be getting. And these metal fume fever, it is mainly seen with zinc. The first thing that you will be getting is zinc. Then apart from that, you will be getting in magnesium, iron and copper. You can remember by the term mics. Okay, so this metal fume fever, it is also known as Monday morning fever, and the main thing that you will be getting this in zinc, magnesium, iron and copper. So with this we are concluding the heavy metal part, and this heavy metal part, it is very important for your exam point of view. Clear? So we will move to the next question now. 5-year-old child ate the product given below and mistaking it for toothpaste. About this poisoning, all of the following is incorrect except for. So they are asking for correct option here. So the product that they have given here, it is a rat poison. So what they have given, it is a rat poison, right? It is the rat poison. And the rat poison main component that they use here is phosphorus. It is phosphorus. So the options they have given, red variant of this poison is luminous. It mainly causes damage to kidney. It causes osteonecrosis of mandible. Readily evaporates from body following death. So here the correct answer is it causes osteonecrosis of mandible because it is the white variant that is poisonous. You usually get two types of phosphorus, that is white or yellow phosphorus, that is this one. This is your white or yellow phosphorus, and the another thing is your red phosphorus. So these are the two things you will be getting, and amongst these two, this white yellow phosphorus, this is the main notorious one. So here what you will be getting is that here it is luminous, it is flammable, and it is the toxic compound. Like this is the main culprit. Okay, this is the thing that is mainly we will be saying. And this red is, it is not at all luminous, it is not flammable, and it is not toxic. And this red phosphorus is what we use in the matchbox. Like in the sides of the matchbox we will be using this red phosphorus. And this white phosphorus, they used to use this in something known as lucifer matchstick. Lucifer matchstick. Now it is banned. So what happens is that this lucifer matchstick, like wherever you strike it against, it will get flame. Okay, so that is this lucifer matchstick, but it is not used nowadays. And these phosphorus, what happens is that they are mainly toxic to liver. They mainly affect the liver, and we will see the features. So what happens is that the main mechanism of action is that they cause uncoupling of oxidative phosphorylation in the liver. Because of that, there will be severe liver damage, and the hallmark is that there will be steatosis. There will be steatosis. Hepatic steatosis is what you will be seeing as a hallmark. And locally, when it is applied over the skin, you will be getting to see some burns. And when there is fulminant poisoning, there will be severe hemorrhagic So in fulminant poisoning, you will be getting hemorrhage. There will be severe hemorrhage. And in subacute poisoning, there will be 3 stages. So it will be seen in 3 stages. So the first stage you will be getting to see this irritant symptoms. Like there will be nausea, vomiting, abdominal pain, all those irritants symptoms you will be seeing. And secondly, there will be some sense of wellness. Okay, there will be sense of wellness, and lot of patients, they might be missed because of this false sense of wellness, but suddenly they will develop hepatic encephalopathy. They will develop hepatic encephalopathy. So these are the 3 stages that you will be seeing in phosphorus. And the main thing in phosphorus, you need to remember that it is very toxic to liver, and it is the white yellow phosphorus that is very, very dangerous. And when there is chronic exposure to this phosphorus, white phosphorus, what happens is that these fumes, when you keep on inhaling this, especially people who are working in matchbox industry, what happens is that there will be osteonecrosis. There will be osteonecrosis of mandible, and it is otherwise known as Lucifer's jaw. It is otherwise known as Lucifer's jaw because it is used in Lucifer matchstick, right? This white phosphorus, you will be getting these osteonecrosis of mandible. Here, do you see? This is the main feature you will be getting in chronic exposure, and people who are working in such industries, they should be periodically evaluated for these diseases. So these are the main things in phosphorus that we need to know. And in the PM features, what you will be getting is that the main thing here you will be getting is garlic odor. The garlic odor you will be getting, and there will be luminous stools and vomitus. Luminous stools and vomitus. And sometimes, like what happens is that, like in the patient who are toxic, like who are toxic with phosphorus, you will get to see something called smoky stool syndrome. Smoky stool syndrome. What happens here is that when they go for toilet, like their stools, they will start to smoke. That is the because of the flammable nature of the phosphorus. So this phosphorus, what happens is that when it is combined with the moisture, it is inert, it will not react, and when the moisture goes off, when it dehydrates, it will start to flame. So that is the main thing with the phosphorus. And the smoky stool syndrome we will be seeing in phosphorus poisoning. And in the PM, the most important thing we need to know is that this phosphorus, it resists putrefaction. This phosphorus, it resists putrefaction. So even after a very long time has passed in the postmortem period, we will still be able to find phosphorus in the body. Clear? So these are the main things we need to know in the postmortem features of phosphorus. So going to the next question, the characteristic features of poisonous snakes are all except. So they are asking the except thing here. So first is your brood fang, compressed shell, nocturnal habit, belly scales are small. So the answer here is belly scales are small, because in the poisonous snakes, the belly scales, they are larger. So you can remember the difference between venomous and non-venomous by using, like, they are venomous, right? So they will be having lot of poisons. They have to put the poison out in the salivary gland. So they will be brooding lot of poisons in their stomach. So belly scale would be large. Since your belly scale is large, the head scales would be small. So the head scales would be small, and the tail and anal plate, that will also be small. Only the belly scales would be larger. And the teeth, here what happens is that here they will be having fangs. In addition to the teeth, they will be having fangs, but in the non-venomous, they will be having this, the normal series of teeth. And sometimes these venomous, they will be having grooved fangs, like canalized. Okay, they will be canalized also. So this is seen in venomous snake. And habitat, it is mostly night. So whatever I am writing for venomous, it is the opposite for non-venomous. Clear? Here it is large, so here it will be small. Here it will be large and large. Here you will have these series of teeth, and here it will be day. The habitat would be day. And these non-venomous, they will be bright colored. They will be bright colored. And here they will be very, very dull colored. Dull colored. Dull colored. So these are the main difference between the venomous and the non-venomous snakes. And in the snake poisoning, it is a very, very repeatedly asked topic. There are certain things we need to know. So the first thing is the identification of the snakes. So cobra, you can easily identify it by the hood. Okay, you can identify by the hood. So this is the hood and this spectacle mark. You can also see the spectacle mark. And kite, you can see these bands. Okay, this bands you can see for the crite. And apart from that, the dorsum, they will be having these hexagonal shaped scales. Okay, they will have these hexagonal scales on dorsum in the midline. Clear? So this is the main feature of crite. And for vipers, they will be having these triangular head. These vipers, they will have these triangular head. This is the main difference between these snakes. And apart from that, the features of the snake, cobra and kite, they are what? They are neurotoxic, right? They are neurotoxic. And their main manifestation would be like locally there will be minimal. Locally minimal and locally minimal and systemic. Systemic, what we will be seeing, it is mainly paralysis. It will be descending paralysis. It will start with ptosis. The ocular muscles, there will be ptosis, then ophthalmoplegia, everything will start with, then it will descend to the dysphagia and all, and finally you will be presenting with respiratory muscle distress. You will be respiratory distress because of the respiratory muscle paralysis you will be getting to see. So this is the main feature of the neurotoxic snakes. And apart from that, something that is specific to cobra and kite is that this kite, the toxin that you see, it is known as beta bungaro toxin. And this toxin, it acts presynaptically. It acts presynaptically. So because of that, like sometimes what happens is that when the neurotoxic snake bite comes to you, you will be starting them with ASV. But certain cases it will not respond. In some cases you will be giving neostigmine plus atropine and there will be improvement. But if there is no improvement even after giving neostigmine and atropine, you can suspect kite. Clear? So because this is acting presynaptically, the neostigmine, it is ineffective. Neostigmine is ineffective in the treatment. So this is the main things related to neurotoxic snake. Now coming to the vipers, that is your hemotoxic snakes. Here what you will be seeing mainly is the prominent local manifestation. So what you will be seeing is the prominent local manifestation. It will start with the swelling of the bite site. There will be swelling in the bite site. Then it will proceed to become edema. Blisters, edema, everything will come. Finally, the whole limb will swell. whole limb will be gone and you will be getting compartmental syndrome. You'll be getting compartmental syndrome. And there will be failure of the coagulation and all the hemotoxic snake, it will be presenting with the prominent local signs and the hematological abnormality. There will be hematological abnormality. And the most venomous in the snakes, like first it starts with the curate. First is your curate, then is saw scale viper, then cobra, then finally a Russell's viper. So this is the order. You can remember by the king size scar. Okay, K for curate, S for saw scale, then C for cobra, then finally Russell's viper. So this is the order of the venomosity. Clear? So this is the main thing in the classification of the snakes. And thirdly, you will get myotoxic snake. This is your myotoxic snake, which are sea snakes, and you can identify them by these paddle like tail. Like tail, it will be paddle shaped, and you will be getting to see myoglobinuria, and there will be renal failure. These are the main features that you will be seeing in all the classes of snake poisoning. And whenever there is a case of snake bite, the first thing that you have to do is the first state that you will be doing is first reassure, because the patient, they will be in a panic mode. You have to reassure them because that bite could be a dry bite, so you have to reassure them. Then whatever you are doing, first immobilize the limb, like the bite site, you have to immobilize that, and do not tamper, like no cartridge, no cryo, nothing. Do not tamper the wound at all. And if at all possible, you can put a wrap. Okay, tourniquet. But that tourniquet, it should obstruct only the lymph, not the blood flow. So that is very, very important. So the tourniquet, the special tourniquet that they can apply is Sutherland wrap. That is the main tourniquet that we can use. And then coming to the diagnosis. So we can identify by using ELISA, but the normal bedside test that we usually use is the whole blood clotting time test. 20 minutes whole blood clotting time test. So basically what happens is that you will get the blood and you will put it in a clear glass container and you will let it sit for 20 minutes. And even after 20 minutes, if the blood is fluid, it means there is hemotoxic snake bite is there. And if it is not fluid, then we can consider it normal. And whenever you get a case of snake bite, the main mode of treatment, it is anti-snake venom. The management is anti-snake venom. And what are the indications? Just by getting the history, you should not give ASV. So there are certain indications for giving ASV. So first, for viper bite, if it is a hemotoxic snake, what is the indication is that initially there should be swelling more than half of the limb. Swelling more than half of limb. Or you should have some positive lab diagnosis. You should have some positive lab diagnosis. Otherwise, you should have some positive systemic signs. All these are important for starting a ASV in a hemotoxic snake bite. Secondly, for a neurotoxic snake, if there is any ptosis, any muscle paralysis like ptosis, facial muscle weakness, dysphagia, all those things if you are seeing, you can start on ASV. Otherwise, if there is positive lab diagnosis, you can start on ASV. So these are the main indications for giving ASV. And apart from the snake bite, in the animal irritants, we have to know one more thing, that is scorpion bite. Scorpion bite, the mode of action is that they will open the sodium channel. So they will open sodium channel. Because of that, you will be mainly getting few symptoms, that will be seen as arrhythmia. Because of the parasympathetic overactivity, you will also be getting priapism. So these are the main symptoms you will be getting in the scorpion sting, and the treatment that you will be giving is prozacin. And this is your blister beetle. Otherwise known as Spanish fly or cantharides. So here what happens is that you will get cantharin. This is the active principle that is being secreted in this insect. What happens is that this cantharin, it can cause renal failure. And when consumed, it can cause anaphylaxis and priapism. Okay, this cantharin is the active principle, and you will be getting priapism, renal failure in this Spanish fly. So these are the animal irritant. Next, going to the plant irritant. What is the active principle in this poison? So here what we are seeing, this is what? This is Semicarpus anacardium. This is Semicarpus anacardium, otherwise known as Dobie's nut. Or what? What is the other name? It is marking nut. It's also known as marking nut. And what is the active principle here? So here it is the bilevenol. Bilevenol is the right answer. And this thing that they have given here, first one, this is Abrus. Abrus precatorius. In case of animal irritants, we have to know the picture, like how it looks like. And we also have to know the active principle in that, and also the medico-legal importance. These three things we need to know in animal irritants. Plant irritants, all the questions they will be asking in this plant irritant will be coming under these three categories only. So they will give you the picture, they will ask you what is the active principle and what is the medico-legal implication, like that they will ask you. So this Abrus precatorius, the first thing, active principle is aberrant. And medico-legal importance is that here, like something known as sui is made with it. So what happens is that they will add this Abrus datura and glass powder. All these three, they will make a paste and they will form needle, that is known as sui. Sui is needle. They will make this needle and they will slap cattle using this sui. So what happens is that this aberrant, this resembles viper venom. Like the mechanism of action, it resembles viper venom, and because of this needle like mark in the cattle, they will think that some snake bit the cattle. So this is how they use this Abrus, and the main medico-legal importance here is the cattle poison. So it resembles viper venom, and the sui is used as cattle poison. That is the main thing we need to know in this Abrus precatorius. And the second thing that they have given here is resinous or castor. So here in resinous, all the parts are poisonous except for the oil. All parts are poisonous except for the castor oil. And the active principle here is that it is ricin. And this ricin, it is a toxalbumin. That is, it can inhibit the protein synthesis. It is a toxalbumin that inhibits protein synthesis. And the main medico-legal implication here is that this ricin, when injected, it can cause multi-organ dysfunction and anaphylaxis. And it is used as biological warfare agent. This is the main medico-legal implication here. And this we already saw, that is semicarpus anacardium, and this one. This is your calotropis. Active principle here is calotropin. Medico-legal implication, calotropis is used for what? It is used for causing artificial bruise. Artificial bruise. And finally, this is croton, otherwise known as Jamalgota. Here the main thing is that the active principle croton, it is also a toxalbumin. It is also a toxalbumin, and this croton, it is mistaken for castor, and the croton oil is poisonous. So this croton oil, it is mistaken for castor, and they make oil from croton, and this croton oil is poisonous and it can cause toxicity. So that is the main thing related to the plant irritants. So in plant irritants, we mainly need to know the picture, the active principle and the medico-legal implications. Next question. A 12-year-old presents to the emergency department with altered mental status, dilated pupil, dry mouth and urinary retention. His friends report he consumed seed of a plant approximately 6 hours ago. On examination, the patient is disoriented and agitated with visual hallucinations and delirium. His vital signs are within normal limits except for tachycardia and mild hypertension. Here, what is the component and the treatment? That is the question. And the options are Datura pralidoxim, Datura physostigmine, yellow oleander digibine, yellow oleander physostigmine. So here all the features that they have given, dilated pupils, dry mouth, urinary retention, delirium, all these, they are atropine features. Features of atropine, that is your datura. So we have two options for datura, and the correct option is physostigmine and datura, because pralidoxim, it is also a antidote for datura, but physostigmine is the first line antidote for datura. Why? Because this physostigmine, it crosses So why physostigmine is that? Physostigmine, it crosses blood-brain barrier. So it crosses blood-brain barrier. So that is the thing here. So that is because of that we choose physostigmine instead of pralidoxin. And a bit about datura. So datura, it is a deliriant poison. And this is the datura and these are the seeds of datura. Seeds of datura. And poisonous part, all the parts are poisonous. All the parts of datura are poisonous. And the active principle here, active principle datura, it is atropine, right? It is atropine. And the seeds, like here, the seeds, they resemble chili seeds. And main thing about chili, that it can cause something known as Hunan hand because of the capsaicin. You will get something known as Hunan hand. And what are the features of datura poisoning that we will be seeing is that you will be seeing all the D's starting from the head. You will be getting delirium, dilatation of pupil. There will be dilatation of pupil and there will be dysphagia, dysarthria, be dry and hot skin, dermatitis, dysuria. Finally, death by respiratory depression. All these you will be getting in datura poison. An antidote, the first line is, we already saw, it is physostigmine. Apart from that, you can also give neostigmine and pralidoxin. But only physostigmine crosses blood-brain barrier, and that is why it is preferred mainly for the central toxicity. And in postmortem features, the main thing related to datura is that this datura, they resist putrefaction for a very long time. They resist putrefaction. And even the seeds, those seeds, it can be found in the stomach of the patient after a very, very long time. Even the decomposition has set in, these seeds will still be visible. So that is the main thing in the postmortem you will be seeing. Apart from that, you will be seeing features of asphyxia. All the features of asphyxia, CPC, congestion, petechiae, cyanosis, all these things will be seen with datura. So moving to the next question. A person comes to the hospital falsely believing that his penis has shrunken. Which substance abuse is associated with this? This phenomenon, this penis has shrunken, this phenomenon, it is known as coro. It is known as coro. And this coro, it is something typically seen with cannabis. So the answer here is cannabis. So cannabis, the other name for cannabis, we can call it as Indian hemp, pot, dope, gross, all those names are the other names for cannabis. And this is how the cannabis looks like. This is the leaves of the cannabis. Active principle is THC, that is tetrahydrocannabinol. Tetrahydrocannabinol. And there are certain forms of cannabis that is very popularly called. First is your bhang. So bhang is a drink. Bhang is a drink made using the stem. So using the stem they will prepare a drink that is known as bhang. Next is majun. It is a sweet prepared from bhang. And third is ganja. So ganja, it is made from flowers. So ganja is made from flowers. So ganja is bald head. So you can remember, like you will put flower in the head, right? So ganja is flower. And charas, it is made from the resin. So charas is made from the resin. So R for R, you can remember, resin. So in cannabis, you will get to see 4 phenomena. First is koro. Koro we already saw. That is the feeling of the penis has shrunken. That is koro. So second is run amok. So what happens is that people, they will go in a, like they will become insane and they will go on a murder streak. That is run amok. Then hashes insanity is that already existing neuropsychiatric manifestation, like already existing psychosis, hallucinations, everything will be exaggerated. Exacerbation of already existing psychological issues. And finally, amotivational syndrome. When there is complete washout, people, they will be apathic. Okay, there will be apathy and they will not be feeling any motivation to do even the normal routine activity. So these 4 things we will be seeing in cannabis: koro, run amok, hashes insanity, and amotivational syndrome. So next, which of the following is a feature mainly of chronic cocaine poisoning? So the options they have given: feeling of well-being, cocaine bugs, tingling and numbness in hands, dilated pupil, rapid pulse and sweating. So chronic cocaine poisoning, amongst the option given, the option that fits best is the cocaine bugs. So this is the correct answer. So a few words about the cocaine. So cocaine, what happens is that it blocks the reuptake of biological amines. Biological amines reuptake, it is blocked by that. And the patient, there will be feeling intense pleasure. So the route of administration for cocaine is that when given IV or intranasally, the action will become very, very quick. There will be instant. And there are certain terms in cocaine that we need to know. First is crack dance. So crack dance is chorea ethetoid movements that you will be seeing in chronic cocaine addicts. In chronic cocaine addicts, you will be seeing this. Chorea, then crack lung is diffuse alveolar hemorrhage. So you will be seeing diffuse alveolar hemorrhage due to repeated inhalation of cocaine. And crack eye is corneal ulcer. Like when there is inhalation of cocaine, some part of the cocaine, like it will be depositing in the eyes. And because of the vasospastic nature of the cocaine, there will be anesthesia and repeated rubbing of the So in cocaine addicts, because of frequent inhalation, there will be deposition of cocaine in the eyes. So because of the vasospastic nature of the cocaine, there will be anesthesia, and repeated rubbing, it can easily result in corneal ulcer, that is known as crack eye. Then finally, crack baby. So this is a baby born to a cocaine addict. What happens here is that these baby, they are more prone for hypoglycemia and respiratory distress. So this is known as crack baby. So these are the terms in the cocaine, and this is the Erythoxylum coca plant. And sometimes they will give picture of the plant and they will be asking you the features. So this picture also we need to know. So this is the Erythoxylum coca. And cocainophagia, it is chronic cocaine drug abuse. Chronic cocaine drug abuse. And in such cases, you will be getting to see palatal and septal perforation. Palatal and septal perforation. And you will also be getting to see black teeth. And finally, formication, that is cocaine bugs. It is simply tactile hallucination. There will be tactile hallucination, feeling of bugs under their skin. It is also known as Magnan syndrome. Magnans. So these are the main things in the cocaine, and there are certain combinations of cocaine which are given specific names. So first is speedball. So speedball is cocaine plus heroin. Then Brompton's cocktail. It is morphine, alcohol, cocaine, and amphetamine. So these are given as a cocktail. They used to give this for the chemotherapy patients in the past. So it is known as Brompton's cocktail. So these are the things important in the cocaine. Moving ahead, the next question. A man was found unconscious on his house and was brought to emergency. Examination revealed pinpoint pupil, and the respiratory rate was 5 per minute, shallow breathing. He had multiple needle track on his arm. He eventually dies despite treatment. What is the likely cause of death? Here the options they have given is opiate overdosing, cocaine, benzodiazepine, air embolism. So there was a case of multiple needle track pinpoint pupil. So all these things are given in the history. So the main thing here we have to consider is the pinpoint pupil. Like just by considering this pinpoint pupil, we can exclude two options. That is your air embolism and your cocaine. So only this opiate and benzodiazepine is remaining. And these reduced respiratory rate, shallow breathing, these are more pointing towards opiate overdosing. Clear? So if we know what are the options, like what are the options that is possible in pinpoint pupil, we can easily answer these type of question. They will give you meiosis, mydriasis mostly. So what are the cases where you will be giving meiosis? So you can remember by this no bar or then scar for meiosis. So first N for nicotine, opium, barbiturate, OPC, benzodiazepine, car for carbamates and carbolic acid. So these are the main poisons where you will be getting meiosis. Next is mydriasis. For mydriasis, the mnemonic is CAD. So here it is cocaine, carbon monoxide, cyanide. A for atropine, amphetamines. Then D for datura. So by remembering these two, we can answer these kind of clinical scenarios. So mydriasis, meiosis, these things we have to remember. Next, a body was brought to mortuary with history of poisoning. Peculiar odor can be appreciated and skin around angle of mouth corroded. Hardening of tongue and posterior pharyngeal structure along with necrotic hardened stomach can be seen. Which of the following is true about this poisoning? So first the poisoning given here. So they have given hardening of the tongue and posterior pharyngeal structure and stomach. So this is your leathery stomach appearance. And this is seen with phenol. They have also given this corrosion of the angle of mouth. So this is a case of phenol. And they are asking which is true about this poisoning. It is not absorbed by skin. It gets converted to pyrocatechol and hydroquinone in the kidney. Causes damage to sensory nerve endings. Chronic poisoning in pregnant mother can cause alkaptonuria in the baby. So amongst these, the correct answer is it causes damage to sensory nerve endings because it is absorbed via skin. Whenever you get a case of phenol toxicity poisoning, you have to remove all the dressings and you have to decontaminate skin also. So this is wrong. And it get converted to pyrocatechol and hydroquinone, that is true, but it happens in the liver, not in the kidney. And these pyrocatechol, when excreted via the kidney, you will be getting carbaluria. Carbaluria. So this carbaluria is green color urine. Green color urine. And when kept long standing, it will become black color. And because of these black color appearance, sometimes it may be mistaken for alkaptonuria. So it is not a like chronic poisoning resulting in alkaptonuria, just this black urine, it will be confused for alkaptonuria. So all these are wrong. This damage to sensory nerve endings, that is true. So that is the correct answer for this question. And a few words about the corrosives. So what we call corrosive is that when that thing, it converts hemoglobin to hematine. When there is hematine formation, we call that substance as corrosive. And corrosive, we will be mainly seeing alkali and acids. So alkali, they cause liquefactive necrosis. They cause liquefactive necrosis. L for L, and acid, they cause coagulative necrosis. So C for C. So the necrosis, kind of necrosis that they cause, we have to know. And there is one exception in the acid that we will see later. So a few words about each specific acid. So first, in boric acid, you will get to see something known as boiled lobster syndrome. So there will be extensive deformation of the skin. So the skin, it will look like a boiled lobster. That is why it is known as boiled lobster skin. And nitric acid, you will be getting xanthoprotic reaction. There will be xanthoprotic reaction, that is all the tissue that is coming in contact, they will turn yellow, especially the tissues with tyrosine and tyrosine like proteins, they will become yellow. That is your xanthoprotic reaction, and it is seen with nitric acid. Then sulfuric acid. Sulfuric acid, it is very important, and here you will be getting to see coffee ground vomiters. I'll be saying the important points. You will be getting to see coffee ground vomiters, black discoloration of oral cavity structures like your tongue, pharynx, everything will become black. And you will be getting to see peritonitis. Perforation peritonitis. It is very common with sulfuric acid. And the stomach that you will be getting here is known as blotting paper stomach. It will look like a blotting paper. So it is known as blotting paper stomach. So these are the important things we need to remember in sulfuric acid. Then next is your oxalic acid. So oxalic acid, what happens here is that it will have the corrosive action. Apart from that, it will also cause hypocalcemia due to formation of the calcium oxalate crystals. So the features that you will be predominantly getting is because of the hypocalcemia. And these shape of the crystals, these calcium oxalate crystals, it will be envelope shaped. Will be getting envelope shaped crystals. Next is the hydrofluoric acid. This is very important because it is the only acid where you will be getting liquefactive necrosis. You will be getting liquefactive necrosis. All others will cause coagulative necrosis. But here, even it is an acid, it is causing liquefactive necrosis. And it will cause decalcification of the bone. And it will lead to formation of calcium and magnesium salts. And this hydrofluoric acid, they will be coming with burns, and the pain, it will be disproportionate. Like the burn will be very small, but the pain, it will be excruciating pain. So disproportionate pain will be seen in this hydrofluoric acid. And coming to the phenol, phenol we already saw, it is absorbed through all routes. Like even via the skin, the absorption would be there. And the features that you will be getting to see here, there will be hardening of structures, hardening of GA structures, leathery stomach. These are the features that you will be getting. And when there is chronic exposure, you will get to see something known as uchronosis. That is mainly yellowish discoloration of the cartilages. That is known as uchronosis. And differential diagnosis, I already told you, because of the black urine, sometimes it may be mistaken for alkaptonuria. And the main thing here we have to know is transudation of phenol. What happens is that when a patient, they consume this phenol, the phenol from the stomach, it will go down, like it will transudate from the stomach to the upper lobe of the liver, upper part of the liver, and the lower part of the lungs. From the stomach, it will transudate. So those parts will also be, you will be getting to see that leathery hardened structure. So this is known as transudation of phenol. Next, which of the following causes formation of diphtheria like pseudomembrane in the pharynx? Options are phenol, aluminum phosphide, sulfuric acid, paraquat. The answer is paraquat. So this paraquat, we are starting with the agriculture poisoning. This paraquat, it is mainly a herbicide and weedicide. And what it does is that it causes free radical damage to lungs. It is a pneumotropic poison and it mainly affects the lungs. And in the postmortem, you will mainly get to see massive lung edema. Like there will be ballooning of lungs. When you open the cavity, you could get to see massive lung. Apart from that, there will be irritant action. That is this diphtheria like pseudomembrane formation. There will be pseudomembrane formation. So next agriculture poisoning we will be seeing is aluminum phosphide. So this aluminum phosphide, it is mainly used as grain preservative. So what happens is that, like, opposite to phosphorus, here what happens is that, like, the phosphorus, when you get moisture, it will become inert. But this aluminum phosphide, when exposed to moisture, it will release a gas known as phosphine. And this phosphine, it is the toxic substance. It is known as sulfose. It is sold as tablets. You will get to see these sulfose tablets, that is the trade name. So this phosphine gas, when liberated, what happens is that it will inhibit the mitochondrial oxygen uptake inhibition. So there will be inhibition of mitochondrial oxygen uptake, and because of that you will be getting to see primary damage to the liver and kidney. So these are the main organs affected in aluminum phosphide. And in PM finding, the main thing that we have to remember here is that precaution, because there is chance for spontaneous combustion of the body. There is chance for spontaneous combustion, and also, like, this phosphine, they may be still present in the body, and when the autopsy surgeon exposed to the phosphine gas, they might become intoxicated. So that is also there. Phosphine exposure, and this phosphine, it is very unstable, and all the things that we are sending for chemical analysis, it should be sent immediately for examination. And we will do one test known as silver nitrate test. Silver nitrate test in this poisoning. So these are the main things related to aluminum phosphide. So next, which of the following is incorrect about intermediate syndrome seen with OP poisoning? So intermediate syndrome, the first option is, it is a delayed muscle weakness mainly affecting upper body. It does not cause any respiratory distress or paralysis. Resolves on its own. Occurs due to redistribution of lipophilic pesticide compounds from the adipose tissue. So the answer here is that it does not cause any respiratory depression or paralysis. So intermediate syndrome is that, so mainly what happens is that a few days, some 4 to 5 days after OP poisoning, the compounds, the OP compounds, they are lipophilic. They will be present in the adipose tissue. So all the lipophilic OP that is present in the adipose tissue, it will be redistributed, and after 4 to 5 days you will be getting the same symptoms again. And here the main symptoms that you will be getting apart from that is that there will be delayed muscle weakness and upper body weakness. There will be upper body weakness, especially facial muscles. And the treatment is, you don't have to do any specific treatment, only symptomatic treatment is done and it will resolve on its own. But there is chance for respiratory distress. That thing we have to keep in mind. This is the intermediate syndrome related to the OP. And OP, you mainly get two classes. One is alkyl and other is aryl. So this aryl, everything will end with ION, like chlorothione, parathione, methyl parathione, diazinon, everything will end like that. And one exception is malathion, which is the alkyl compound. Okay, this malathion, it is also known as kill bug, and this HETP, TTPP and this malathion, these are the main alkyl compounds we need to know. And the main thing here is that these aryl compounds, they need activation in the liver. Aryl compounds, they need activation in the liver while alkyl does not need. And the mechanism of action of OPC, it is very, very commonly asked. So it will cause inhibition of carboxylic esterases, not just the acetylcholine esterases. All the carboxylic esterases it will inhibit. Like you will be getting acetylcholine esterases in the RBC, in the plasma, in the neurons. All those things it will be inhibited by this opiate components, and because of that you will be getting symptoms, and these symptoms they are widely divided into muscarinic and nicotinic. So muscarinic is all your increased secretions. You will be getting all the increase in the salivation, lacrimation, salivation, lacrimation, emesis, dysuria, urination, diarrhea, all the increase in the secretions. Apart from that, you will also be getting bradycardia and bronchoria. This increased secretion, this bronchoria, this is known as killer bee of OPC, and meiosis. So these are the dumbbells of muscarinic symptoms. And nicotinic symptoms you will be getting mainly muscle weakness, areflexia, tremors, chorea, convulsions, and hypertension. So all these are nicotinic symptoms. So these are seen with OPC poisons. And test for this, the diagnosis, you can use acetylcholinesterase from plasma RBC both, but the ideal indicator is RBC acetylcholinesterases. This is the ideal. And we can also do p-nitrophenol test for diagnosis. And the management, the normal A, B, C, D, E. So airway management, everything. The airway management is the first mode of treatment in OPC, and the specific management you will be giving atropine. So you will be giving atropine, and this will only inhibit the muscarinic symptoms. So you will be giving atropine, and the specific antidote you will be giving is oximes. And with oximes, you have to remember one thing, that is aging, the phenomenon of aging. So oximes, they should be administered as soon as possible. If you delay the administration of oximes, the bond between the OPC and the acetylcholinesterase, they will be unbreakable. So that phenomenon is known as aging. So atropine and oximes, you mainly need to remember. In the PM changes, you will be getting to see kerosene smell and asphyxial signs. Intermediate syndrome we already saw. And OP induced neuropathy, it is a delayed sequelae, and it is due to neuronal acetylcholinesterase inhibition. So these are all about the acetylcholinesterases. Next is your carbamates. So carbamates, they are like mostly brother of OPC. So all the features will be same as OPC, but less intense. And the main thing here we need to know is that oxime is contraindicated. Oxime is contraindicated. Next is organochlorine compounds. Organochlorine. Here the main components we need to know is capone, endrin, These are OC, and their mechanism of action, it is totally different from OPC and carbamates. What they do is that they open neuronal sodium channels, and because of that there will be tremors, chorea and convulsions. And we will get to see something known as capon shakes. That is, this capon is one OC compound, and you will be getting to see the tremor that is known as capon shakes. And this DDT and enrin. This enrin is known as plant penicillin. They used to give this for all insect infestations, and this DDT, it is the only OC, only organochlorine compound that is still being used. All others are banned because of the excessive toxicity. So only OC that we still use. Next, examination for drunkenness. Smell of alcohol present, conjunctiva red, walks in straight line, talk normally. Which of the following is true? He has consumed alcohol. Consumed alcohol and is under the influence of alcohol. Consume alcohol but not under its influence. Has not consumed alcohol. So this examination of drunkenness, there is a specific pattern in which we have to give the opinion. So what happens is that whenever a case is brought to you by the police, you have to make sure that the person is arrested, because like consent is a tricky part in this. Like if they are arrested, you can do examination even with the consent. But if they are not giving consent and they are not arrested, you cannot do examination. That is the thing here. So in the examination, what are the things you need to do is that first you have to rule out diseases, like certain diseases like carbon monoxide toxicity, like certain diseases, it will be mimicking like condition of drunkenness. So those diseases you have to remove by taking proper history. Then you have to look at the general manner, how they are behaving, what is the state of their dress, all those things you have to consider. Then you can give them certain phrases like British constitution, like certain tongue twisters you can give them, and you can test their speech and whether there is any slurring or not. That is the main thing that you need to note, slurring is present or not. And you can ask them few questions to test their memory, and you can ask them to write whether they are able to write without any tremors, whether they are writing in straight line. All those things you can ask. Then you can make them walk, you can test for the gait, you can ask them to walk in a straight line, or you can ask them to walk and turn, and you have to know whether they are swaying or not. All those things you can test. Then test for muscle coordination, finger nose test, then finger nose finger test, all those tests. And buttoning unbuttoning shirt, all those things we can ask. Then reflexes, all the deep tendon reflexes we can do, and they will be sluggish or delayed in case of drunkenness. So all these things we will be doing. Like apart from the lab investigation, all these clinical examination should be done. And for lab examination, we will be taking blood and urine samples, and the blood samples, it should be kept in sodium fluoride. That is the preservative, ideal preservative for alcohol analysis. And after doing all this, we have to give the opinion. And opinion, it will be given in three format. So first scenario is that, so physical examination. So first is your physical examination, then lab diagnosis, and how you will be giving opinion. So first scenario, if the physical examination, the conjunctiva is red, there is slurring of speech, like all the features of drunkenness is present. And the lab diagnosis is also coming as positive. What you will give is that the person, they have consumed alcohol. Consumed alcohol, and he is under influence. And it's under influence. That is the opinion you will be giving. Next, second scenario, here what will happen is that here there is no physical signs, okay, no physical signs, and there is smell of alcohol present. Here the smell of alcohol is present, and lab diagnosis, it may or may not be positive. Okay, so under this scenario, like all the physical examination is coming as positive, only the smell of alcohol is there and the lab diagnosis is coming, you will be giving the person has consumed alcohol and not under its influence, not under its influence. And finally, third scenario, like no smell, no physical examination, everything is negative. Okay, everything is coming as negative, even lab is coming as negative. Here you will be giving the person has not consumed alcohol. So these are the three opinions that you will be giving. So here if you see the question, like here they have given smell of alcohol, conjunctiva red, walks in straight line, talks normally. So physical examination is fine, but there is smell of alcohol. So here what we will be giving is the person has consumed alcohol but not under its influence. So this is the opinion that we will be giving, and this is the correct answer. So smell of alcohol is there, but all the physical examination it is coming as negative. So we will be giving has consumed alcohol but not under its influence. And the blood concentration for driving limit in India, it is 30 milligram percentage, and by 80 you will be getting nystagmus, and 150 milligram percentage you will be getting motor incoordination, and if it goes up to 400 there will be coma and death. So these are the blood concentration, and you will be using one formula for alcohol blood concentration estimation, that is Widmark formula, A equal to PRC. Just remember the formula, just the name and the formula, that is enough. So Widmark formula you will be using to estimate blood alcohol concentration. So next, a 50-year-old factory worker was brought to emergency room with complaints of headache, vomiting, blurring of vision after he consumed local spirit. Which of the following is used for treatment of his condition? So consumption of local spirit, it is the case of methanol. So methanol toxicity. And for methanol toxicity, what we will be using? It is fomepizole. 4-methylpyrrosol, that is what we will be using. So methanol toxicity, what happens here is that there will be histotoxic hypoxia. Because of that, you will be getting to see all the features. That is, first you will be getting to see vomiting, abdominal pain, vision, there will be snow field vision. Sometimes there will be blindness also. Snow field vision and blindness. Serious, there will be depression of myocardium. Depression of myocardium. And CNS, there will be coma, convulsions. And kidney, you will be getting acute tubular necrosis. You're getting acute tubular necrosis. So these are the features that you will be getting in methanol, and usually there will be a latent period. Like after the consumption of the methanol, there will be a latent period. Only after that the symptoms will start to appear. And the main management here is that first we will be giving ethanol. So why? Because methanol itself is not toxic, right? Methanol, it needs to be converted to formaldehyde and formic acid. After that only it will become toxic. This formic acid is the toxic compound, and this ethanol we can give to prevent this conversion. But if we give excess of ethanol, that itself can become issue. So we will give something known as fomepizole, that is 4-methylpyrrosol. 4-methyl pyrazole. So this is a competitive antagonist. It is a competitive antagonist of alcohol dehydrogenase. So it is a competitive antagonist of alcohol dehydrogenase. So it will prevent the conversion of the methanol. And the main cause of death in methanol, it is metabolic acidosis. That is the main cause of death. And in the postmortem, you will get to see fluid blood. There will not be any postmortem clotting. The blood would stay fluid till the end. So that is the main thing you will be seeing. And the color of the blood will also be green because of the methylene blue contamination. In the methanol, you will be getting to see green color. That is also seen. And next, in the alcohol, we will be seeing ethylene glycol. This ethylene glycol, it is used as antifreeze. In the Western countries, they will use this to reduce the freezing point of the fuels. Okay, so it is used as antifreeze. And what happens is that same way methanol is getting converted into formic acid. This will be converted into glycolic acid and there will be hypocalcemia and hypomagnesemia. All these will be seen in ethylene glycol. And chloral hydrate, this is known as mickeyfin. So this, what happens here is that it is having mechanism of action similar to benzodiazepine. So what they do is they will mix this chloral hydrate and alcohol and they will give us as knockout drops. Alcohol and they will give that as knockout drops and it is used for drug facilitated sexual assault. Drug facilitated sexual assault. Next, substance used in detergent suicide. So the answer is hydrogen sulfide. So what happens is that in Japan, there was one trend where they used to make hydrogen sulfide gas by combining toilet cleaner and bathing salts. They combine these two and they prepare hydrogen sulfide. Like when they mix these two, hydrogen sulfide was prepared and they inhaled the hydrogen sulfide and they did suicide and they were found inside the bathroom cabins. So that is why the name detergent suicide is given. This hydrogen sulfide, it is also known as sewer gas because it is abundantly found in the sewer, okay, and also known as knockout gas. So when given in excess concentration, it can cause immediate knockout and death. That is why it is known as knockout gas. And the smell of the hydrogen sulfide, it is the peculiar rotten egg smell. And they act by inhibiting cytochrome oxidase, just like the cyanide. Just like cyanide. So all the antidotes that we are giving for cyanide, we can give it for hydrogen sulfide also. The treatment would be same. And the main features that you will be seeing here is there will be brain damage. And the postmortem color hypostasis would be green. Not just the hypostasis, all the organs. Blood, everything will be green. And it hastens decomposition. And in the brain, you will be getting to see lot of features, that is greenish gray matter. So next is carbon monoxide. Carbon monoxide, it is a colorless, odorless gas. And mechanism of action, so it is a colorless, odorless gas, and the mechanism of action, it has higher affinity. It has higher affinity to heme containing proteins like your hemoglobin, myoglobin, all those heme iron containing proteins. It has higher affinity. So it will get attached and the bond is like very strong and very almost irreversible to break. So because of that, oxygen will not be delivered to the body. And the level, toxicity level, when the carboxyhemoglobin concentration, it is between 10 to 20%, it is known as mild toxicity, and you will not be getting to see any symptoms. And when it becomes 30 to 40%, there will be confusion and dizziness, and 50 to 60% there will be coma. More than 80% when the concentration goes, there will be rapid and instant death. And the postmortem features that you will be mainly getting here is the cherry red hypostasis. This is very important. Cherry red hypostasis you will be getting in this. And there will be formation of blisters in the flexion areas. So in the flexion areas there will be blisters. And brain, you will be getting to see necrosis of basal ganglia. Basal ganglia necrosis, especially over the putamen, you will be getting to see. So these are the main postmortem features in the carbon monoxide toxicity. Next, coming to the cyanide. Here cyanide, like, it is rapidly absorbed when inhaled. When ingested, the time taken to action, it is kind of slow. And the antidotes for cyanide, it is very, very important. You have to remember Eli Lilly antidote. So the first is sodium nitrite, amyl nitrite, and sodium thiosulfate. So these are given as a combo. Okay, all these three are given together, and there are other antidote, that is dicobalt irritate. So these are the antidotes for cyanide. And the PM feature in cyanide is that there should be precaution while performing the autopsy. There is fear of exposure to cyanide gas. So the precaution is must, and while preserving the cyanide, it can escape easily. The gas, it escape easily. So the preservation, it should be done like when you preserve the tissues, along with the preservative, you have to add a layer of paraffin. Like in the top, you have to add paraffin to prevent the escape of the cyanide. So this thing we need to remember in cyanide poisoning. And next question, all of the following symptoms are caused by substance shown below except for. So this is what they are shown here. This is ergot. See this thing, this black color, this is ergot. This is nothing but dried sclerotorium of Claviceps purpura. So this is dried sclerotorium of Claviceps purpura. And what it does is that it stimulates androgenic receptors. All the androgenic receptors it stimulates. And the features that you will be getting here is formication you will be getting, hallucination you will be getting, vasospasm you will be getting, vasodilatation you will not get. So this vasospasm, because of the stimulation of the androgenic receptor, you will be getting to see this vasospasm, and there will be intense burning sensation in the skin. That is known as St. Anthony's fire. So vasospasm resulting in burning fire sensation. So burning fire sensation. And St. Victor's dance, it is chorea that is seen because of ergot. And skin, you will be getting to see this formication, that is your tactile hallucination. So this tactile hallucination, it is also seen in this, not just cocaine. In this also you will be getting to see tactile hallucination. The next food poison we will be seeing is Lathairism. So this is your Lathyrus sativa. Lathyrus sativa, also known as kesari dal. This is your kesari dal. And the condition that you will be getting is known as Lathairism or neurolathyrism. So you will be getting neurolathyrism. When you cook it properly, like cook it for a long time, all the toxic component will be gone. That toxic component that causes this Lathairism is this beta and oxyl amino L-alanine. Okay, when you cook properly, it will be gone. But if it is not done properly, we will be getting this neurolathyrism. It will start with scissor grind. Okay, there will be muscle spasm. Okay, there will be muscle spasm, and because of that, there will be scissor gait, and it will proceed to spastic paraplegia. It will proceed to spastic paraplegia. Next is this. This is Argemona mexicana. So this is Argemona mexicana. This is also known as prickly paw. It is also known as prickly poppy, Argemona mexicana, otherwise known as prickly poppy. And the main component, the toxic principle that you will be seeing here is the sanguinide. Okay, and it will cause epidermic dropsy. So you will be getting to see congestive cardiac failure like features. Okay, there will be vascular leakage. Okay, congestive cardiac failure like features, and it will be mixed with mustard. Okay, so it is contamination with mustard seeds, main adulterant. Next, the poison detected in exhumed body. So arsenic, acid, carbon dioxide, hydrogen sulfide. So the thing is, with poisons we have to remember certain things. So first is which delay putrefaction. That is, when that poison is present in the body, the whole process of putrefaction, it is slower. So these three components we will be getting. First is phenol, then heavy metals, then zinc chloride. So you can use it by PHCs. Okay, phenol, heavy metal, zinc chloride. Then poisons that are formed after postmortem. That is alcohol, cyanide, and carbon monoxide, AC. Okay, AC is formed after death. And rest is putrefaction. That is, those components, they can be found in the body even after long time. Okay, those you can remember by DNB COPM. Okay, so datura, nicotine, barbiturate, cyanide, corrosives, OPC, phosphorus, pancuronium, and all the heavy metals. Okay, you can remember by DNB COPM. Okay, so these are the poison terms that we need to know. And the question here is the poison detected in exhumed body. Okay, so arsenic we can detect. So that is the thing. Okay, even after a long time, like the poison, it will resist putrefaction. So arsenic is the correct answer for this. So next question, match the following column. Heroin. So heroin is brown sugar, right? So A is 4. Then Spanish fly, we already saw. It is blister beetle. Then abrus, the other name for is gunchi, also known as kidney peas, rosary beets, all these names. Okay, so abrus is gunchi. Then aconite, aconite is blue rocket. So this is the answer, A4, B2, C1 and D3. So this is the correct answer for this questions. And aconite, it is a cardiac poison. And aconite we can see, so aconite, it was mainly used as a arrow poison. Okay, initially it was used as a arrow poison. And the other names for aconite is wolfsbane, blue rocket, metazagar, monk's foot and devil's helmet. And the poisonous part, all the parts, like all the parts of aconite are poisonous. All the parts are poisonous, especially the roots. Okay, especially the roots, and these roots, they can be mistaken for horse radish. Okay, for horseradish roots, they can be mistaken and consumed. Okay, so this is the main thing. And the active principle here is aconitin. So there are a lot of active principle, but the main active principle that we need to know is aconitin. And the features that you will be getting, the specific features is that you will be getting Torsedis D pointers. Okay, Torsedis D pointers and hippus. Hippus is alternate dilatation and contraction of pupil. So this is something you will be mainly seeing in aconite. And this is the picture of aconite. Okay, this purple color, flower. This you have to remember. They will simply give you the picture and they will ask you some questions. Okay. So this is aconite. And next, this thing. This is cerebra odellum. Okay. This is cerebra odellum. And this is also a cardiac poison. This is also known as suicide tree. And these, they can be mistaken for mango, unripe mango, okay, and maybe consumed. Next, this one, these flowers, these are known as digitalis. See, they are looking like fingers. The flowers, it will look like a finger. That is why the name digitalis is given. So what they mainly do is that they will activate sodium potassium ATPase. So because of that, all the arrhythmias, all sort of arrhythmias you will be getting. And the main treatment is digibind. That is a specific antibody. So digibind is a digitalis specific antibody that you will be giving. And next, this is your oleander. So this oleander, this action is similar to digitalis. Action is similar to digitalis, and the treatment is also the same. You can use the same digibind. And finally, this is nicotine. So nicotine, they will mainly activate the nicotinic receptors. Okay, the nicotinic receptors, it is activated. Nicotinic receptors. And initially, when there is consumption poisoning, there will be increase in the heart rate. Initially, heart rate, respiratory rate, everything will increase, and then everything will go down. This is something you will be specifically seeing in nicotine poisoning. So these are the cardiac poisons. Next, a few words about spinal poisons. So the first thing, you have to know which is central and which is peripheral. So central is nux vomica. So first is your nux vomica, which is centrally acting. Peripheral, you have hemlock, okay, and curare. So these are peripheral poisoning. So nux vomica, the other name is strychnine. Okay, strychnus, nux vomica, also known as dog button, because they used to use this for killing dogs. So it is known as dog button. And poisonous part, all pots are poisonous. All are poisonous except for uncrushed seed. Okay, except for uncrushed seed. Uncrushed seed. And the active principle here is strychnine. So the active principle is strychnine. The main mechanism of action is that they will inhibit inhibitory neurotransmitter. They will inhibit inhibitory neurotransmitter, that is your glycine, and they act in the anterior horn cells. And the features that you will be getting, this is opisthotonus. So this is opisthotonus. And when there is, this is your back arching. When there is lateral arching, it is known as pleuristhotonus. And empresthotonus is forward arching. So empressotronus is forward arching. And this is the seed. This is the seed of Nux vomica. And the main thing is we have to differentiate strychnine from tetanus, and that can be done by, like tetanus, it starts from jaw, while strychnine everything starts simultaneously. And also this convulsions, initially they will be clonic, then become tonic. Here from the starting itself everything would be tonic. So these are the main differences between the strychnus and the tetanus. Apart from that, you will have history of poisoning. Here you will have history of trauma. So these are the main differences between these two. And with this, we are ending the toxicology. Rest of the forensic we will see after lunch. Thank you. Everyone, we are back with the session again. First question, which of the following statements are incorrectly given with respect to biological stain detection test? So the options are choline from seminal vesicle is detected by Florence test. Second is P30 is not useful in cases with azoospermia. Then thirdly, ALDR test is confirmatory test for blood stain. Finally, immunological tests for blood stain help in identifying the species. So they are asking the incorrect options. Now, the correct answer for this is this one. P30 is not useful in individuals with azoospermia and ALDR test is a confirmatory test. So the correct answer is 2 and 3. And we will see about the biological stains. So first, for seminal stains we will see. So first, seminal stain examination. Here mainly we have these 5 examinations, these 5 tests we will be seeing. So first is serum acid phosphatase test, and here we will be looking for serum acid phosphatase. This is what we will be testing for. And next test is Barbario test. The Barbario test, here what we will be looking for is choline. We will be looking for choline. And next is your Florence test. In the Florence test, we will be looking for what? And CPK, like we will see the each test together and we will see finally. And here the mnemonic for here is that this is S bank. And for Florence, it is FCP. So in Florence test, you will be looking for 1 second. Excuse. Okay, here you will be looking for spermine. And in CPK, you will be looking for creatine phosphokinase. You will be looking for creatine phosphokinase. And in P30, you will be looking for prostate specific antigen. So these are the things you will be looking for. Next, the color of the test. In this, only Barbario and Florence we need to remember. In Barbario, you will be getting yellow color. Yellow rhombic crystals. This is what you will be getting. Here in Florence test, you will be getting brown color. Okay, so F for Florence, C for choline and B for brown. Here S for yellow, then S for spermine, then bank for Barbario. So this is the mnemonic. And this P30 CPK, we don't get any specific color. And special feature here. In case of P30, you can get positive test even person with azoospermia. They will give positive result. And this SAP, even old denatured stain, they will give positive result. So these are the special feature related to seminal stain test. So basically we have 5. One is serum acid phosphatase. Next is your Barbario, then Florence, CPK and P30. What are the substances that we test for? First in SAP, we will look for serum acid phosphatase. In Barbario, we will look for spermine. And in Florence, we will look for choline. CPK, it is creatine phosphokinase. P30, it is prostate specific antigen. The special feature here is that in case of P30, you can get positive result even with azoospermic individuals, and serum acid phosphatase old denatured stain also we will be getting positive results. Next, for seminal stains, for finding out the sperm, the confirmatory test, it is always microscopic test. Microscopic tests are always confirmatory. Like you have to find at least a single unbroken motile sperm to call a positive seminal stain slide. Okay, this is the confirmatory test for seminal stain. Then for immunological studies, that is for species identification. To identify the species, whether it was animal or human, for that we do precipitin test. Precipitin test, otherwise known as immunological test. Immunological test. So these are the main things that we use in seminal stain examination. And after that, next question, what is the best method to preserve a blood-stained kerchief recovered from a crime scene? So you are basically going to preserve a clothing which is stained with blood. The answers are dry over spirit lamp and preserve it. Stain area folded and preserved in plastic bag. Rinse with water to prevent contamination. Stain area folded and preserved in paper bag. The correct answer here is this. Stain area folded and preserved in a paper bag. So what happens is that when you get a blood stained clothing, what you have to do is you have to air dry it. You have to air dry it. And like you should not put it in direct sunlight, because putting in direct sunlight, it will denature the protein and we will not be able to get the result. So no direct sunlight. No direct sunlight. Only air drying is done. And the stained area, it should be folded properly so that if two areas are stained, those two should not come in contact. Okay, you should fold like that and you should always put it in paper bag. It is always put in a paper bag, because if it is put in a plastic bag, there will be chances for decomposition. So paper bag is always preferred. Next. So next, during a police investigation, the police found some bones in open space. Which of the following tests can be used to differentiate between human and animal bones? So, as I said earlier, for species identification, it is always immunological test. If you want to identify the species, if you want to differentiate human and animal bones, this is the thing you should do. That is precipitin test. So the answer is precipitin test. Apart from that, we have Teekman, Barbario, Takayama. All these are tests for blood stains. Now, in the blood stains, in the blood stain test, we have two types of tests. First is your presumptive test. So this presumptive test, they have high sensitivity and low specificity. So if the test is coming as positive, that means it could be blood. But if the test is negative, then it is surely not a blood stain. So this is the importance of the presumptive test. And this presumptive test, all the presumptive tests, they act on the peroxidase principle. Okay, the peroxidase activity of hemoglobin, the ability of the hemoglobin to do this peroxidase to prevent the nascent oxygen. That is the main principle upon which these presumptive tests are acting. And there are few presumptive tests that we need to know. So first is your benzidine test, and this test, even old stains, clear stains, everything, treated chemically treated stains, all those stains, they can give positive results with this. And here you will be getting blue color. If there is presence of blood, you will be getting blue color. And next is your orthotoledin test. This test, it was a replacement for benzidine. Since benzidine is carcinogenic, it we started doing this orthotoledin test, and here also you will be getting blue color. Then third is your Castle-Meyer test. Here Castle-Meyer test, you will be getting pink color, and it is also known as phenolphthalein test. The other name is phenolphthalein. So P for P, just remember, phenolphthalein test. Then thirdly, you have the leucomalachite green. Here you will be getting green color. Then finally, you have two tests, that is luminol and fluorescein test. Here there will be fluorescence. There will be presence of fluorescence. When there is blood stain, when you apply these luminol and fluorescent reagent, there will be fluorescence. Okay, and these luminol, it is the best presumptive test. Of all the presumptive tests, this is the best. And next we have the confirmatory test. So after this we have the confirmatory test, and in this we have the microcrystals test. We have basically three microcrystals test. First is hemine or Teekman. Hemine or Teekman test. Second is hemochromagen or Takayama test. So second is your hemochromagen or Takayama. Then finally you have vaginal. Thirdly you have the vagina test. And amongst these three, the main test is Takayama, because this is the best confirmatory test. Even old stains you will be getting positive results. So this is the best confirmatory test, and you will be getting pink feathery crystals. You will be getting pink feathery crystals in this test. And in case of Teekman and vaginus, you will be getting other tests. Okay, you will be getting like positive results, but still this Takayama is the best. Then finally, the spectroscopic methods. These spectroscopic methods, they are more reliable. They are more reliable for confirming the blood. And finally, for species origin, we have the precipitin test. The same precipitin test we will be using for all species differentiation like blood, semen, bones, everything. We will be using this precipitin test. So basically for blood, you have presumptive test and confirmatory test. Presumptive is benzidine, orthotolidine, Castlemayer, leukomalachite green and lumina. So LMG is leukomalachite green. So these are the presumptive tests, and amongst this luminol test is the best one. And for confirmatory, you have microcrystal test. Here you have the hemine, hemochromagen and vaginal. Amongst these, hemochromagen is the best confirmatory test, and the most reliable test for blood stain is spectroscopic methods. And for species identification, we use precipitin test. So these are about the biological stain identifications. So next one, an accused of murder charge was subjected to narco analysis as part of interrogation. Which of the following statement is incorrect with respect to lie detection test? So the options are, according to Indian Constitution, no person of accused of any offence shall be compelled to witness against himself, which is true. Murmur uses P300 waves, that is also true. Forced use of truth serum by doctors is a kind of torture, that is also true. So, finally, skin conduction is not tested in polygraph. This is the wrong answer. So, skin conduction, it is tested in polygraph. So, basically in polygraph is what? It is your lie detecting test. In polygraph, you will be measuring heart rate, BP, respiratory rate and skin conduction, that is your sweating. You will be testing all these, and based upon the response we will be identifying whether the person is lying or not. That is your polygraph. Second is brain mapping. This is also known as brain fingerprinting. Here EEG will be done. So EEG response to certain informations would be measured, and based on that we will be identifying the criminal. Here the wave that we use known as P300. It is memory evoked potential. MR is memory evoked potential. And the expansion of murmur is memory encoding related multifaceted EEG response. So this is about brain mapping. And finally, narco analysis. And the main drug that we use in narco analysis is sodium pentothal. It is also known as pentothal or emetol test. Okay, it is also known as emetol test. And apart from that, we will be using barbiturates and these three QBC. Okay, all these things we will be using for narco analysis. And the main thing in relation to narco analysis is that its validity. Like even though if the person, if they say the truth, like if they say that, like let's take an example, if a person, he is actually the perpetrator of the crime, okay, and by lie detection test, by polygraph we are identifying the truth, but even if you are sure about that lie detector test, we cannot use only that as an evidence and we can give him punishment. It is not like that. It will only be a corroborative evidence and it does not stand any value, and it should only be done with consent of the accused. Consent of the accused, it is mandatory. Without the consent, you cannot do these lie detection tests. So these are the important things related to this. So next, as per POXO, which of the following statements are correct? They are asking the correct statement. The doctor must report cases covered under POXO mandatorily and it will be punished if failed to do so. It does not cover child pornography and child trafficking for sexual purposes. Female cannot be accused under POXO Act. False cases will be punished. Any sexual assault committed by family member is punished under indecent sexual assault category of this act. So first we will see about POXO and we will come back to this question. So first question, who are all covered under POXO? Like whether it is only girl or boy. So anybody, okay, both girl and boy, child below age of 18 years, okay. Everybody, it is a gender neutral act. It is a gender neutral act, that is it covers both boy and girl. And also the main thing here is that not just the victims, like the accused also. The accused can also be of any gender. That is under rape, that is your 376 IPC, you can only accuse a male, but under this POXO both female and male they can be accused. That is the most important thing here. Like both the accused victim, they can be of any gender, right? So these are the people who are covered under this act. And what are the aspects that is covered under this? So the first thing here is that penetrative sexual assault. You have penetrative sexual assault. Second is like which is non-penetrative, like touching vagina, like that, okay, touching any private parts, that is your sexual assault. Then thirdly, you have the sexual harassment, any word, any act insulting the modesty, that is sexual harassment. Then you have finally one more term called aggravated sexual assault. Aggravated sexual assault, it can be either plain sexual assault or penetrative, okay. Here what is that? When it is done by person of trust, that is someone like a relative, someone like teacher, someone like that, okay, some person of trust, when it is done by that, we call it as aggravated sexual assault. And apart from that, it also covers child trafficking and child pornography. All these are covered under POXO. So not just the sexual assault, also the harassment, child pornography, trafficking, everything is covered under POXO. Trafficking especially for sexual purpose. So all these are covered under POXO. And the most important aspect here is reporting. So whenever you come across a case of POXO, there is mandatory reporting. You must report. Mandatory reporting. Otherwise, you can be penalized. Like there will be fine with or without 6 months imprisonment. So there is mandatory reporting. Whoever, like be it a teacher, doctor, anybody who is coming across a case of POXO, they must go and inform the police. So that is the important thing here. And the proceedings, all the proceedings, it will be done in a child friendly manner. Everything will be done in a child friendly manner. Like if they want to do the investigation at the home, they can do. If they don't want to go to the police station, they need not go. And the trial, if they want to do it in camera, they can do. Like all things, everything that child prefers, they will be doing. And there will be speedy disposal. There will be speedy disposal. They have special POXO codes. And one more thing here is that since there is mandatory reporting, there will be punishment for false cases, okay. There will be punishment for false cases. All these things, that is important and specific to POXO. Clear? So what are the aspects that is covered and who all are covered, and like what is the reporting and what are the proceedings that we need to know here. So coming back to the question, so they are asking which are correct, okay. So this option is right. They must report the case mandatorily and will be punished if fail to do so. So this is correct. Option 1 is correct. Next, it does not cover child pornography. No, we just now saw it covers child pornography also. So it is incorrect. Female cannot be accused. That is also incorrect. False cases would be punished. Yes, that is true. Then any sexual assault committed by family member, it will come under indecent sexual assault. No, it will come under aggravated sexual assault. So answer is 1 and 4. So this is the correct answer for this. So next question, Vishaka guidelines deals with what? So Vishaka guidelines, it deals with sexual harassment at workplace. Okay, so this is the answer, sexual harassment at workplace. So what happened is that, like, for defining what is sexual harassment, they created certain sections in the IPC. Okay, in the previous IPC we had certain sections, and those sections now they are given under 74, 75 of BNS. Okay, so these are the new BNS. Okay, you need not learn IPC for the exam, you just need to learn only the BNS, because BNS has been passed and it has been implemented. This is what we are following now, so you have to read BNS only. So here, this sexual harassment, they have defined it under section 75 of IPC. And if there is criminal disrobing, it will be coming under 76. And voyeurism, that is your, voyeurism is what? It is peeping Tom. It is coming under 77 BNS. Okay. Then 78 is stalking. Then 79 is insulting the modesty of the women. So, like, at the end of this presentation, I have given a complete list of the BNS, the important BNS that you need to remember. So, here I have given only the sexual harassment. Okay. So, these are the 75 to 79 mainly dealing with the sexual harassment. So, next question. In an examination of victim of sexual assault, Toledan blue dye test is done to identify. So, this is your Toledan blue. Here, do you see this thing? This is your Toledan blue, and this is usually done to identify recent micro injuries, because it will not be readily visible. So, we use this dye for identifying those. Okay, so this is the answer for this. So, while examining case of a sexual assault, there are certain things we need to consider. So, the first thing is that we have to take proper history, and examination should be done by his, as per the history, according to that. Okay, according to the history, like if they are giving a history of, like, oral penetration, of if you are taking vaginal sub, what is the point? Okay, so you have to take proper history, and according to that we have to conduct the examination and sample collection. And this consent part is very, very important with relation to examination of the victim. So, this consent you have to take for general physical examination. Okay, all your medical examination you have to take consent. Then, for forensic examination, that is your local examination, private parts examination, you have to take separate consent. Then, for collection of evidence, collection and preservation of evidence, you have to take consent. And also information to police, whether I want to inform the case to the police or not, for that also you need to take consent. So, for all these four you have to take consent separately. And if they are refusing, we have to document proper informed refusal. We have to take proper informed refusal. Clear? And what are the samples that you will be collecting? It will depend upon the history, but the main thing to note here is that the time period up to which you can collect. If you are looking for biological stains, okay, biological stain samples, like for semen, you can collect maximum up to 3 days. For sperm, you can collect maximum up to 4 days. So, ideally it is 72 hours only, but this 96 hours is a grace period. Clear? And if it is in the, like, clothing or something, if it is a dried state, you can collect as long as it is available. There is no time limit for that. Then the BNS sections, the IPC replacement for rape, okay, the 376 IPC, it is starting at 63, okay. So, 376, you just take away the 7, it is starting from 63. Here, what you have to notice that there everything was given as A, B, C, D, E, right? Here everything is given a number, And here the main thing you have to is 70 is gang rape. Okay. 71 is repeat offenders. If you look at the sequence, it is the same. Okay, there like 76 A, B, C, whatever there, the sequence is the same. Just the number has changed. Okay, you need not remember the sequence. It is already the same sequence. Just have to remember the starting and the ending number. Clear? And one more thing is that here, this printing and publishing any matter related to court proceeding without permission, disclosure of identity of certain offences, everything is coming under here only. There it will be separate, but here it is coming under this BNS itself. So these are the BNS sections related to rape. Then statutory rape is when the age of the girl is less than 18 years. Okay, when the age is less than 18 years. And sodomy examination, we will be, in case of victim, we will mainly do lateral traction test. Here we will look for the dilatation, relaxation of the anus. In case of passive agent, okay, habitual, that is also habitual passive agent, you will be getting positive results. Okay, there will be dilatation of the anus even in the absence of the feces. Okay, that is the main test you will be seeing. And sodomy, when done with consent, when the both parties are consenting, it is not an offense. Okay, when there is absence of consent, it is considered as an offense. Next, in the sexual offenses, we will also see about paraphilia. So first is transvestism or eonism. It is what? It is wearing opposite sex clothing. Okay, opposite sex clothing. Then frotchism or touchism. It is rubbing the private parts. It is rubbing private parts. Then this is sadomasochism. This is sadomasochism. Sadism and masochism. Okay. So sadism, it is gratification by infliction of pain. Okay, and masochism, it is opposite to that. And with respect to paraphilias, we have to know the other names also, because sometimes they will give you the other names, or sometimes they will give only the explanation and they will ask you to match it. Okay, so in paraphilia, that is important. So next is voyeurism, that is peeping tom or scoptophilia. Okay, scope. Okay, that is scoptophilia. Then exhibitionism. Apart from that, you have incest. Okay, incest is sexual relationship between blood relatives. Okay, here blood relatives are involved. So first is electra complex. It is between father and daughter. Then next is Oedipus. Oedipus complex is mother and son. Then finally pharaonic complex, it is between the siblings. It is between the brother and sister. Okay, that is incest, and incest is not illegal in India. So next, a man is brought by his wife as he calls other women and achieves sexual gratification by talking obscene and sharing obscene pictures. And what does the patient most likely have? So this is what? This is scatologia. Okay, so like this they will give you the explanation and they will ask you the terms. So we will see the important terms here. So first is lesbianism. It is also known as tribadism, and this active agent, passive agent also we need to know. It is dyke and femi is the passive agent. Next is sodomy. Sodomy, the other names are Greek love and buggery. Here the pederasty is child. Catamite is the passive agent, and when it is an old person, it is known as gerontophilia. Next, the other names masturbation, ipsation or onanism, that is self-stimulation. Then uranism is gratification by fingering or fondling. Then urolagnia and unionism. These, you should not confuse between uranism and unionism. Okay, unionism is urine and coprophilia is feces. Clear? And scatologia. Okay, scatologia, auto, just remember, hearing using obscene languages, oh, just remember. And erotophonophilia is lust matter. Okay, so these are the important paraphilias that we need to remember. Next, a 24-year-old woman present with excessive desire for sexual intercourse, which is called as, the answer is satyriasis. Okay, so here Frochurism and masochism we already saw in the paraphilias. Next left is nymphomania. So nymphomania is, it is counterpart of, female counterpart of satyriasis. Okay, if the female is having excessive sexual desire, that is nymphomania. Next is your impotence. Impotence and sterility. Okay, so sterility is inability to produce an offspring. Okay, here we have to know what is impotence, what is sterility. Okay, here only the sexual act is gone. In impotence only the sexual act is affected, but sterility, the ability to produce the offspring is gone. And here the main thing they will be asking is voiding, divorcing marriage. Okay, so first of all, what is null and void? So when we say null and void, it means marriage not legal. Okay, it never happened. What is that? Like if person has already married someone and they are marrying again, that second marriage will not be considered as a marriage. It is not considered legal. Okay, that is null and void. Then what is null? Like it is dissolving the marriage. Okay, it is dissolving marriage, and this be given for impotence. Okay, okay, and divorces can also be given. Clear? So these are the things. And impotence quad hack, this is psychological. This is psychological impotence towards a specific women. Okay, that is impotence quad hack. And fecundation ab extra, this is getting pregnant by the semen that is depositing on the thighs, like other than the vulva. Okay, that is fecundation ab extra. So these are the important terms in virginity and sterility. So next question, a female fake pregnancy and still presents a child later to blackmail a man. What is this child called as? So this is a case of supposititious child. Clear? So when there was actually no child and they are giving a false child, that is this. Now what is posthumous child? So posthumous child is a child born after death of the biological father. After death of biological father. That is your posthumous child. Now, what is this thing? Superfecundation and superfetation. So, what are these? What is the main difference in this? So, here you can easily remember by this term. So, in case of fecundation, you have C. Okay. So, C means cycle. There will be cycle. Okay. One cycle. And you have 2 ova. Okay. And these will be fertilized by two coitus, two different copulatory events, it will be fertilized. Okay, it can be either the same partner or different partner, it does not matter. Okay, so what you will have is that you will be getting two fetus with same age. Okay, this is superfecundation. And the second one is superfetation. This is not seen in human. Okay, so what happens is that there will be two cycle and two ova, and the age of the fetus would be different. Okay, so this is normally not seen in human. This is the main thing we need to know. Okay, fecundation, you have the C seen in human, one cycle, two ova and two coitus. Okay, that is superfecundation. Next is phantom pregnancy. So here what happens is that there will be sense of false pregnancy. The female, they will think that they are pregnant, but they are actually not pregnant. Here there will be abdominal distension, like all the presumptive signs of the pregnancy you will be seeing. Okay, these abdominal distension, absence of menstruation, increase in the size of the breast, everything will be seen, but they are not actually pregnant. Okay, this is purely hormonal. Okay, that is false pregnancy. Then next, atavism. Atavism is when the child is showing grandparents, okay, grandparents characters. Okay, that is atavism. Okay, then thirdly we have surrogacy. So surrogacy, what is surrogacy and who are eligible? So as per the Surrogacy Act, a couple married couple for a period of 5 years, at least 5 years, with proven infertility, is eligible for surrogacy. And single widow female or divorcee, they are also eligible for opting for surrogacy. And the main important thing here is that only altruistic surrogacy is legal. Okay, altruistic is only legal. No commercial surrogacy is allowed under this act. And there are also certain criteria for the surrogate mother. So the surrogate mother, they should be a blood relative of either of the parent, and they should have at least one child. Okay, they should be preferably married and they should have at least one child. So these are the criteria for becoming surrogate mother, and they can be only once in their life. Only once in their life they can be a surrogate. So these are the important things coming under Surrogacy Act. Next, an abandoned dead fetus was brought to mortuary by the police for autopsy. On examination, fetus, the crown heel length was found to be 35 and the ossification center for thallus was seen. Age of the fetus is calculated using which of the following? So, ossification center for thallus, it is seen at 7 months. Okay, thallus is 7. Calcaneum is 5. Okay, and lower end of femur, it is seen at 9 months. So these are the important ossification centers in intrauterine we have to remember. Okay, and this thallus is very important because this gives the age of viability here. So this is 7 months, and for 7 months, like above 5 months, the rule that we use is Morrison rule, because less than this Hasse rules, it is for less than 5 months. We will do the square root, right? That is for less than 5 months. Above 5 months, we will be dividing by 5. And that is Morrison's rule. Okay, Hassay's rule is first 5, Morrison is the next 5. So this is the main thing seen here. Next, a fetus was diagnosed to have congenital anomaly which is incompatible with life at 28 weeks of pregnancy. Hence, the mother wants to medically terminate her pregnancy. Which of the following is true? MTP cannot be done. It can be done after filing a litigation in High Court. It can be done after approval of 2 RMP, and it can be done after approval of medical board. Here the correct answer is it can be done after approval of the medical board. So as per the recent amendments in the MTP Act, the thing is that MTP can be done for few reasons. So first is for the well-being of the mother. If it is affecting the mental or physical health of the mother or emergency, you can do. Second is any substantial fetal anomaly. Then if the pregnancy was due to rape or incest. Finally, failure of contraception. Failure of contraception. So these are the 4 indications for doing MTP. And for these 4 indications, they have given also the who all can do all those things they have defined. So up to 20 weeks, okay, all can be done. Up to 20 weeks, all 4 reasons can be done, and you need only 1 RMP to do that. Between 20 to 24, except for the failure of contraception, 3 can be done and you need 2 RMP. Okay, and anything beyond that, okay, anything beyond that, especially if it is a case of fetal anomaly, if it is a case of substantial fetal anomaly, there is no time limit. Okay, there is no time limit. Only if the board agrees. Okay, we need medical board's consent. Medical board's consent, be it 24, 26, 28, if the medical board is consenting, we can do MTP in case of substantial fetal anomaly. Okay, and this thing, the second thing, it is mainly for cases of rape. Okay, so these are the important things that they have specified in the MTP Act. Apart from that, we have to get only the consent of the female. Okay, only the pregnant lady's consent is needed. If it is a case of minor or mentally unsound, we need case of the guardian. Okay, guardian's consent we will be taking. Next, match the following. We have to match the gunshot injury. So first, so we have these wounds. Okay, so first we will see which wound or what. So first is your contact wound. Next is abrasion collar, exit wound, and entry wound. So first we will see about them. So first we are starting with entry wound. So the entry wound, you will be getting to see certain features. So first is the wound defect. You will be getting round wound defect. Okay, and after that you will be getting grease collar. Okay, after that you will be getting grease collar, and after that you will be getting the abrasion collar. Okay, you will get abrasion collar, and after that the contusion collar. This is the sequence. Okay, so here if we go from outside, you will be getting C, contusion, abrasion, grease. Okay, contusion collar, abrasion collar, and grease collar. Okay, you can remember by the term Kagger, CAGR, Kagger. Okay, so this is the sequence. Okay, so this is how the entry wound will be presenting, and this grease collar, it is mainly due to the bullet wiping. And these two, this is due to the mechanical stretching of the skin. This is the reason for these two. And in case of bone, especially the skull bone, these will be seen differently. Okay, if the wound is entry wound, in case of entry wound, you will be getting to something called beveling. Here, do you see this? This chipping of bone, right? This is your beveling. This beveling, it is seen in the inner table. Clear? And in case of exit wound, this beveling will be seen in the outer table. Entry wound, it is coming inside, so you will be getting beveling in the inner table. Exit wound, it is going outside, so you will be seeing the beveling in the outer table. Okay, so here the inner table is free. Okay, here if you see, you could see the chipping of bone. So this is a case of entry wound and this is a case of exit wound. Now, apart from that, the characteristic of exit wound we will be seeing. So exit wound, they will be having more hemorrhage and destruction would be more, and there will be no grease collar, abrasion collar, all of things. Okay, the cagger, it would be absent in the exit wound. So these are the main things you will have to know in the exit wound. Now this question, if you see this A, here we can see the, here this is your contusion collar, and this thing, this is your abrasion collar. So we are seeing all these. So this is a case of what? This is a case of entry wound, right? So A is your entry wound. Then B, here you are seeing beveling in the out. Okay, inner table is free. So this is a case of exit wound. This is a case of exit wound. Then C is a case of entry wound because beveling is seen. And D, it is a case of what? Here, do you see this? This abrasion. This is looking like some pattern, right? This is muscle impression. Okay, this is muscle impression. And this denotes that it is a contact wound. Okay, when the gun is in contact, when the muscle is in contact with the body, because of the expansion of the gases, you will be getting this muscle impression. Clear? So this is the contact wound. So the answer for here is that, so we have two entry wounds. The option they have given one abrasion collar also. So for A, we will put abrasion collar instead of entry wound. Okay, so A is 2, right? So for one contact wound, 1 is D, 2 is A, 1 is D, 2 is A. Then exit wound is C, 3 is C. So this is the correct answer for this. 1D, 2A, 3C and 4B. So this is the correct answer for this. Next, in case of skull, we can also identify the sequence of fracture, and the rule that we use for this is known as Puppy's rule. Okay, so like this case, if you see here, see this fracture line is going like this, and this fracture line, it is coming like this and it is ending. Okay, it is not going beyond this. Okay, this fracture line, it is not going beyond this fracture line. So this means this fracture 1, this has come first. Okay, this was formed first and this 3 is after that. Okay, it was formed after that one only. Okay, by using this we can identify the sequence of the fracture, not just the firearm. Even from fall from height, any other mechanical trauma, we can identify the sequence of the fracture using this Puppy's rule. Now next question, all of the following are correct except for, so here they have given A and B. So the options are A occurs due to burned gunpowder, B occurs due to unburned gunpowder, A can be wiped with wet gauze, not B, B can be wiped with wet gauze, not A. So first of all, what is A and what is B, we will see. So A is what? A is here. Do you see the small? This is tattooing. Okay. And B is blackening. Okay, here it is not given properly. See, we will take this part then. Okay, this part. Okay, I will see this area. This is your blackening. Okay, the part I showed, this is your blackening. And here, do you see the small stippling over here? These are all your tattooing. Okay, these are all your tattooing. Now blackening, tattooing, we will see how it occurs. So when the bullet is coming out of the gun, along with the bullet, three other things will also be coming. So first is your flame. Second is the smoke, that is due to burnt gunpowder. Okay, that is due to burnt gunpowder. And thirdly, you will be getting this unburnt gunpowder. Okay, and finally the bullet. So this flame, it can cause singeing of hair. Okay, then this burnt gunpowder, it will result in blackening. And finally this unburned gunpowder, it will result in tattooing, right? So these are the things that is coming along with the bullet. And this blackening and tattooing, you can easily differentiate by using one technique, that is wipe with a wet gauze. If you wipe with a wet gauze, this blackening, it will go off. Okay, blackening can be wiped off, and tattooing, it cannot be wiped off. Clear? So, it cannot be wiped off. Okay, so the answer for this is that if we consider A as blackening, B as tattooing, we can say this A can be wiped with wet gauze, not B, because A is blackening and B is tattooing, which cannot be wiped off. And with this, we will take a break. And the main thing with tattooing is that it will go deep into the dermis. Okay, deep into the dermis. Clear? Next, in case of a contact wound, what are the things that you will be seeing? So This is a case of contact wound. When you like put that muscle and when you press the trigger, there will be release of gases, and because of the expansion of the gases, you will get to see this wound, which is stellate shape. Okay, stellate shape wound. This is something you will be typically seeing in a contact bullet wound. Okay, contact wound with a bullet, that is your rifle firearm. Okay, this is how the contact wound will look like. And apart from that, you will also be getting muscle impression. We already saw, right, that muscle impression we will also be getting. Okay, and using all these blackening, tattooing and this muscle impression and all, we can find out the range of the gunshot injury. So for rifle, to find out the range, we have to mainly see these. Okay, flame effect, smoke effect, that is blackening, and finally tattooing. Okay, now if the flame is present, smoke is present, tattooing, all three are present, means it is close. The range is close. Okay, and this flame, it will travel to only a very short distance. Okay, so in case of intermediate range, you will not get to see the flame. Okay, and you will be getting to see smoking and tattooing. These two you will be getting to see. And finally, in the long distance, okay, distant range, you will not get to see these two. Okay, you will be only getting to see the tattooing. Okay, this is also known as intermediate. Okay, this depending upon the relative distance, you will be getting this. Okay, you will be getting either smoke and tattoo both, or you will be getting only the tattoo. And if the range was really far away, okay, if it is like really from far away, you will be getting to see only the bullet hole. Okay, only the bullet hole you will be getting to see. All the flame, smoke, tattooing, everything would be absent. So if it is a close range, you will mainly get to see this flame effect. Okay, if flame effect is present, it is a case of close range. And you can say whether it was contact or not by looking at the stellate shape wound and muscle impression. Okay, then next, in case of intermediate, you have two. Okay, either you will be getting smoke and tattoo both, or you will be getting only the tattoo. These both will be coming under intermediate. And in the far range, you will be getting only the bullet hole. Okay, these three, all three would be absent. And this is how you determine range in a rifle firearm. Okay, and in case of shotgun, how you will be determining is that like this. So contact, you will have the same. Okay, like the stellate shape you will be getting. And in shotgun, you mainly get pellets, right? These pellets, they will stay together till a distance. Okay, till a certain distance they will stay together and they would form a single hole like this. Okay, and these single holes, it will start to become satellite hole by 2 to 4 meter. Okay, you will be getting to see this satellite pellet holes, that is there will be a main hole and around that you will be seeing small holes. Okay, this is your satellite hole and it will be seen between 2 to 4 meter. And finally, the central hole, it will be completely absent by 4 to 6 meter. And beyond 6 meter, there will be no uniformity. Okay, it will be completely spattered. Okay, one will be here, one will be there, like that spattering would be present. Okay, here we have to mainly remember this satellite pellet holes. Okay, it will be seen in 2 to 4 meter range. Okay, so these are about the ranges in the rifle and the shotgun. Now, there are certain phenomena related to gunshot injury. We will see that. So, first, this is your Rayalaseema phenomenon. Okay, Rayalaseema phenomenon. So, what happens here is that like they will cause a stab injury, okay, and they will put a bullet inside, okay, they will stab and they will put the bullet inside to confuse the police. That is Rayalaseema. Okay, then next here, this is your piggy back bullet. Okay, so this is usually seen with some defective firearms. Okay, mostly in defective firearms, two bullets would come together. Okay, two bullets would come together in a single shot. In a single shot, you will be getting two bullets. Okay, and the back bullets, the nose would be flattened like this. You will have the flat nose. Okay, flat nose on the back bullet. This is very important because sometimes you will be getting to see only one entry hole, but there will be two exit. Okay, one entry, two exit, and there might be sometimes you won't be getting to see the bullets also. Okay, so this is you can identify whether it was a case of piggyback or not. You have to consider this while seeing such cases. Okay, then finally we have this ricochet phenomenon. Okay, ricochet phenomenon. Here what happens is that like the bullet, it will go hit some hard object. Okay, it will go hit some hard object, then it will turn. Okay, it will turn and hit target. Okay, so this is your ricochet phenomenon. See here, this is your entry. It will go strike here and then it will come like this and it will lie like this. Okay, so ricochet is when there is an intervening object in between the target and the bullet. It is a ricochet phenomenon. And another thing we need to know is markings in the bullet. Okay, markings of bullet. This is also known as bullet fingerprinting. What happens is that you will get to see two markings. One is primary marking, another is secondary marking. Okay, and you can identify this using a comparison microscope. Okay, by using a comparison microscope, you can identify all these. Okay, so this primary marking, it is something specific to the manufacturer. Okay, specific to manufacturer. Like you can identify the make and model of the gun. Okay, this secondary marking, it is specific to each and every individual gun. Okay, specific to each and every individual gun. You will be able to identify the particular gun using this secondary markings. Okay, next coming to the ammunitions. So ammunitions, you have in rifle, you have the bullet. Okay, bullet is for rifle firearm, and this pellets. Okay, this pellet is for shotgun. Clear? Okay, so the main thing in the anatomy that we have to know is that in case of shotgun, you will be getting to see wad. Okay, you will be getting to see wad. Here there will be no wad in the bullet. Apart from that, everything is the same. You will be getting to have a primer, gunpowder and the projectile. Okay, the projectile here is the pellet, there it is the bullet. Clear? So these are the main thing you need to know in the ammunition. And this is how the rifle firearm look like. Okay, this is your rifle. Do you see the markings? And here it is completely clear, right? This is your smooth bore firearm, and this is your rifle firearm. Okay, in case of rifle firearm, you will be getting these alternate grooves and lands. Okay, depressions are grooves, elevations are lands, and distance between two opposite lands. Okay, the distance between two opposite land, it is your caliber. Clear? And this, do you see the size of the muscle? It is decreasing as it is going, right? This is known as choking. And this is done to increase the velocity of bullet. Increase the velocity of bullet, and it is mainly done in shotgun. Okay. To impart terminal velocity, we will be doing this choking. Okay. This is seen only in shotgun. Clear? So, with this, the firearm is done. Now, we are going to mechanical injuries. So, this question, the injury depicted below can be caused in which of the following scenario? So, what they are showing here? See, there is a injury over here, and in between there is a clear space. Okay. This is a typical case of tram line bruise. Okay. This is a case of tram line bruise. And this tram line bruise, how it occurs is that when struck by a metal pipe, okay, like a wooden lathi or a metal pipe, like something cylindrical, if they struck, the blood vessels at the border here, do you see here, they will rupture, okay, and they will form these bruises, and the central area, it will be cleared off. Okay, the central clearing would be seen. Okay, this is your tramline bruise or railway road bruise. Okay, and this is usually caused by a single strike. Okay, when a metal pipe or lathi, something cylindrical, when a single strike is done, you will be getting to see this. And in case of bruise, there are certain things we need to know. First is ectopic bruise. So, first is ectopic bruise, that there will be injury at one side, but the blood collection, it will be seen at another side. So, example is this battle side. Here you will be getting to see in the mastoid, right? And here you are getting to see in the eyelids. Okay, this is raccoon sign or spectacle hematoma. These are usually seen in anterior cranial fossa fracture. Okay, and this one here, this is sixpenny bruises. This is sixpenny bruises, and this is seen in case of throttling. And finally, in case of bruise, the main thing is that we have to differentiate it from a hypostasis. Okay, hypostasis versus a bruise. And the main way that you can differentiate is by giving a incision test. Okay, by giving a incision test. In this incision test, even after giving incision, if the discoloration stays, it is a case of bruise. If it goes away, it is hypostasis. Clear? This is how you differentiate mainly hypostasis and bruising. Now, coming to the color of the bruise. So, initially it will be fresh, okay, because of presence of oxyhemoglobin. Then, after few hours, because of the deoxygenation, it will become blue. Then, after that, it will become brown by 4th to 5th day. Then, green, then yellow, finally, it will become normal. Okay. These are the time period, and what are the pigments involved in that. So, you can remember this by STB, okay, stabilizer. Okay, brown, it is due to hemosiderin. Green is due to hematoidin, and B is due to bilirubin. So, remember it by this STB, because initially you won't confuse, only these three will be confusing. Okay, using this you can identify. Okay, this pigments which is causing the color you have to remember. Next question, which of the following is not characteristic of the injury depicted below? So, the injury that they are showing below, it is a case of laceration. It is a case of laceration, a type of laceration, okay, avulsion, right? So features of laceration, they are asking which is not. Okay, so presence of tissue bridges, yes, it is a feature of laceration. Then split laceration occurs when blunt forces applied to the region where underlying fat is more, yes. Presence of crushed hair bulb, true. Direction of injury cannot be identified, that is also true. Okay, so here the thing is that here the answer is the split laceration occurs when blunt forces apply to the region where the underlying fat is less. Okay, so this is the correct answer. Okay, so split laceration is what? That is your incised looking laceration. It is actually a laceration, but it will mimic a incision. Okay, so this is usually seen when the underlying fat is minimal. Okay, when the underlying fat is minimal, you will be seeing this. Like example, your forehead, scalp, shin, all those area, you will be getting this. And the main difference between an incised looking laceration and the incised wound is that, so here if you see, this is a true incision, and this here, it is a incised looking lacerated wound. The main difference here is that, first, marginal abrasion, it will be present. Okay, marginal abrasion will be present in laceration. Okay, and secondly, the borders, okay, the border of the wound would be ragged, okay, uneven, and you could see tissue bridges. While here there will be no abrasion and no tissue bridges, and it will be clear cut. Okay, it would be clear cut. Then finally, in case of incised looking laceration wound, the hemorrhage would be less. Okay, because the blood vessels would be crushed. But in case of incision, there will be more hemorrhage. Okay, there will be more hemorrhage since the blood vessels are clearly cut. And main difference is that hair bulb. When you look at the hair bulb under microscope, it will be crushed. Here it will be crushed. In case of incised wound, the hair bulb would be cut. It would be clearly cut. So these are the main differences between incision and incised looking lacerated wound. Clear? And another type of laceration is that this avulsion. Okay, it is also known as flaying when there is a grinding force acting. This is known as avulsion. Clear? And finally, this is a hybrid between laceration and a incision. That is a chop wound. And this will be seen along with the fracture of a bony structure. Okay, this fracture will always be present. Only fracture is that you can call it as a chop wound, and it is usually caused by heavy cutting weapon like a machete, axe or something. Okay, it's a heavy cutting weapon. Done. Next, so which of the following statement are wrong with respect to incised wound? So they are deeper in the beginning and become shallow towards the end, right? This is known as tailing. Okay, this is known as tailing of wound. So initially they will start deeper, and as it goes, it will become superficial. This tailing of wound is something specific to incised wound. So this is a right option. Okay, so second, penetrating incised wound result in severe bleeding. There is no thing as penetrative incised wound. You get penetrative stab wound. Okay, you don't get penetrative incised wound. Then chop wound is a subtype of incised wound you can consider. Okay, it is a hybrid between laceration and a incision, but it is mainly a laceration. And seppuku is an example of incised wound? No. Okay, so seppuku is what? It is harakiri, and it is a stab wound to abdomen, right? So it is not an example of incision. Okay, so the wrong options are second is wrong, fourth is wrong. Okay, second, third, fourth. Okay, everything is wrong. Okay, so incised wound, it is having this tailgating. Okay, this tailing of wound is there. And also another thing you will be seeing is defense wound and also hesitation cut. Hesitation cuts. Okay, so this is one, this is two. So we will mainly see these. Now hesitation cuts are multiple superficial parallel cuts in exposed areas. Okay, over the wrist or something. People with suicidal tendency, they will do this. There will be multiple superficial cuts. Okay, this defense wound, it can be incised or incised looking laceration. It can be anything. It is mainly seen over the flexor aspect of the arm. Okay, this is seen over the arms and the hand. Okay, this active and passive difference is that when they are trying to catch, okay, when they are trying to catch the weapon, they will be getting these active defense wounds, and when they are simply trying to prevent themselves from getting beaten, okay, they are acting there. Okay, they are trying to grab the weapon. Here they will simply protect themselves. Okay, they will simply protect themselves. This is passive defense wound. Okay, so these are the two things in this. And this thing, see here you have the superficial multiple cuts. This is your hesitation cuts, otherwise known as tentative cuts. Clear? So these are all about the incised wound. Then this is your stab wound. Okay, this stab wound, you have three types. So first is puncture, that is similar to the injection. Okay, then second is your penetrative. Okay, penetrating wound. Okay, so penetrating wound is that it will enter body cavity. It will enter the body cavity, but it does not come out. Okay, it does not come out. That is your penetrating wound. Then finally you have the perforating stab wound. You have the perforating stab wound. Here there will be one entry and there will be one exit. It will enter a cavity and it will come out. That is the three types. Okay, penetrative, puncture and perforating. These are the three types of the stab wound. And in stab wound, we will get to see something known as hilt mark. Here, do you see this abrasion here? This is abrasion caused by the knife margin. Okay, these are specific to the knife and we can identify the weapon using that. And depending upon the weapon, if it is a single edge weapon, okay, you will be getting wedge shape stab. Okay, you will be getting like this. Okay, then if it is a double edged weapon, okay, like both ends are sharp. Okay, if it is a double edged weapon, you will be getting a spindle shape. Okay, you will be getting a spindle shape like this. Okay, so here what you are getting, it is a spindle shape. Clear? So these are the types of stab wound that you will be getting, and this I already told you. This is harakiri and it is stab to abdomen. Another name for this is seppuku. So these are all about the stab wound. Next, identify the type of fracture. Here The fracture line, it is going like this. Okay, do you see? It is going like this. So, this is a case of hinge fracture. Okay, when it is starting at one end and traversing across the pituitary fossa and ending at the other side, it is a hinge fracture, and it is also known as motor-cyclist fracture. Okay, motor-cyclist fracture. We will see about all the fractures now. So first, this one. This is your depressed fracture. This is also known as fracture a la signature. Means you can identify the weapon. This is usually caused by hammer-like weapon, that is a weapon with small striking area. Okay, a weapon with small striking area, you will be getting this. Okay, so this is also known as fracture alert signature, and here there will be severe brain damage. Okay, the brain damage would be severe. And here, see this one. What you are seeing here is that here it is around the foramen magnum. Okay, so this is your ring fracture, and it is seen with fall from height. Okay, it is seen in fall from height. And this thing, this is pond fracture. This is pond fracture, and this is seen in infants, and there will be no brain damage here. There will be no brain damage. Then we already saw this. This is hinge fracture. This is hinge fracture. This is your fissure fracture. A single linear. This is your fissure fracture. Okay. Then finally, this is gutter fracture. Okay. This is gutter fracture. See here, you see this chipping. Okay. This is usually seen in gunshot injury. It is usually seen in gunshot injury, and it is also known as keyhole fracture. Clear? So these are the important types of fracture, and finally this is diastatic fracture. Okay, here like along the suture lines. Okay, along suture lines you will be getting to see the fracture line. This is diastatic fracture. Okay, these are the important fractures in the skull, and whenever these skull injury happens, we also have to know about coup and counter coup injuries. Okay, so this is coup and this is counter coup. Okay, coup means at the site of injury. Okay, at the site of injury you will be getting. Counter coup, opposite to the site of injury, opposite to the site of injury, and this is mostly seen in case of frontal region. Okay, mostly in the frontal you will be getting. Next is your road traffic accident. Okay, this is road traffic accident. So here you will get to see primary impact injury, secondary impact injury, then secondary injury. So what happens here is that when the vehicle is, it is striking the pedestrian here, right? So this is the primary impact. Okay, first contact. And once it struck the victim, he will fall upon the vehicle. Okay, that is your secondary impact, and after that he will fall towards the ground. That is the secondary injury. This is primary impact, this is secondary impact, and when he falls down to the ground, that is your secondary injury. Okay, and this primary impact injury, the typical injury you will be seeing is tibial fracture, that is also in the shape of wedge. Okay, wedge shape fracture. Okay, clear? So this primary impact, it is very important. If the case is an adult, you will be getting in tibia. If it is a child, you will be getting in the femur. Okay, you will be getting in the femur. So this is the main thing in this pedestrian. Apart from that, you have two more injuries. One is run over, another is roll over. Okay, so run over is like the vehicle, it will go above the body. Okay, the vehicle and the body would be under it. Okay, roll over is the body would be thrown in air. Okay, it will scoop the body and it will throw it around. Okay, that is the roll over. And here you will be getting mainly avulsions. Okay, here you will be mainly getting gray separations. Clear? And finally, tailgating. Tailgating is when a bike, it comes and hit the vehicle and goes inside. Okay, like fast moving bike, it will behind a truck or something. Okay, that is tailgating. So these are the things you will be seeing in pedestrians. Okay, now coming to the occupants of the vehicle. Okay, in case of driver, like occupant, generally in the occupant you will be getting to see sternal fracture because of the steering wheel. Okay, because of the steering wheel you will be seeing that. Then airbag injuries, the airbag injury you will be seeing. Then the important thing, because of the seat belt, you will be getting to see root of mesentery tear. Okay, and ladder tears in aorta. All these you will be seeing. Apart from that, you can also see patellar fracture. Patellar fracture and posterior dislocation of hip and chance fractures in lumbar vertebra. So all these are seen in the occupants of the vehicle. Clear? Amongst these, the seat belt injury is very important. Then next, coming to the cranial hemorrhages. So you mainly have EDH, STH, SAH and intracranial hemorrhage. So EDH, it is outside the dura, right? STH beneath dura. SAH beneath arachnoid. And in parenchyma you will be getting in intracranial hemorrhages. And the main artery implied here, it is middle meningeal artery. Here it is bridging vein. Here mostly it is aneurysms. Okay, and trauma or hypertension. Here it is mostly pathological. All these things are seen. And the most important thing you will be seeing is lucid interval. And it is commonly seen in EDH. STH also you will be getting, but more common in case of EDH. Clear? Next, regarding examination of the following victim, all are correct except. So, keep reference scale above the wound and take the photo by keeping the camera on same plane of the wound. Two swab technique for saliva collection. Complete description of injury as seen. Making a mold using vinyl polysiloxane. Okay, here the correct answer is this. Okay, so why? Because here how we have to take photo is that you have to keep the camera perpendicular. You have to keep the camera perpendicular to the plane and then you have to take a photo. Okay, that is the correct way. Like this, you have to put two scales and you have to take in the perpendicular angle. Clear? Okay, this is how you should ideally take a photo. And this is what? This is bite mark. Okay, this is your bite mark. Next. Next, we are coming to torture. So, we have to match the following. So, first is Picana, Black Slave, Bastinado, Wooden Horse. So, Picana is electric torture. Okay, so one is C. Then, Black Slave, it is hot skewer shoved up the anus. Okay, 2 is D. Bastinado is foot whipping. Then, Wooden Horse is forced straddling. Okay, 4 is B. So, this is the answer 1C, 2D, 3A, 4B. Okay, this is the answer for this. Okay, so we will see pictures of the torture and they will give you a picture and they might ask you what is it. Okay, this thing, this is hog tie. Okay, they have tied the arms and the legs together on the posterior side. Okay, this is hog tying and this is bastinado. Okay, bastinado or foot whipping. Other names also they can ask you, also known as falanga. Okay, falanga. Yeah, and this is Spanish donkey or forced straddling, and this is picana or electric torture or cattle prod. Okay, electric torture. Then this is tiger bench and this is parrot's perch. Clear? So these are the important times, and this one, these both are submarino. This is dry submarino and this one, it is wet submarino, and this one, it is chepua. Here they will roll this rod along the foot. Okay, and sometimes people will be standing at both ends also. Okay, this is chepua. So these are the important torture methods that we have to know. Then coming to the autopsy technique. A newborn baby was found dead few hours after delivery and brought to autopsy to rule out any pathology and foul play. After examination, the surgeon made incision over the body, and which of the following type of incision is preferred in type of cases. So, it is a case of newborn baby, and the type of incision we prefer in newborn is inverted Y-shaped incision. Clear? So, you have basically X, Y, I. Okay, these are the different incisions. Okay, so first thing here, this, okay, this A, this is your I shaped. Okay, it is starting from chin and it will go to pubic symphysis. This is your I shape. Okay, then B. Okay, this I shape, and then B is your Y shaped. Here it will start from mastoid. Okay, on either side it will start from mastoid and it will go to the pubic symphysis. This is Y. Now, like I said, inverted Y. You have inverted Y, that is, it will start from the chin it will go till umbilicus. Okay, it will go to umbilicus, and from there it will divide into two. Okay, it will have two limbs and it will go to the inguinal canal. Okay, on both side inguinal canal it will go. Okay, so it will start from here and from here it will go like this. Okay, this is your inverted Y, and this incision that they are showing here, see this one they are showing here, this is your modified Y shape. Okay, this is modified Y shaped. Okay, and this will go beneath the breast. Okay, this will go beneath the breast on either side. Okay, mainly for cosmetic purpose we will be doing this incision. So these are the type of incision, and finally here do you see this, this is going like this. Okay, this is your T-shaped incision. Okay, and this will start from acromion. Okay, this will start from the acromion to pubic symphysis. So these are the type of incision. Now we will see what are the indication for each and every incision. So first, this inverted Y, I already told you it is preferred in infants to preserve the umbilical vessels. Okay, to preserve umbilical vessels we will be using this. Okay, here umbilical vessel, and this modified Y shape it is mainly for cosmetic purpose. Okay, this is mainly for cosmetic purpose, and this I shape, this is the most commonly used incision. Okay, this Y shaped and this Y shape, this Y shape and this T shape, both they are used for neck structures. Okay, to see neck structures both. Clear? These are the indications for the each and every type of incision that we are using. Apart from that, we also need to know the types of autopsy. We also need to know the types of autopsy. Okay, basically we have medico-legal autopsy, pathological autopsy, psychological autopsy, and finally autopsy. Okay, there are few other types also, but these four you mainly need to know. So medico-legal autopsy, the main thing here is consent is not necessary. Okay, you mainly need the requisition from the investigating officer, the police, they have to give the requisition. You don't need consent from the relatives. Okay, and this pathological autopsy, consent is must. This is the main thing you need to know. And psychological autopsy, it is verbal autopsy. Okay, and autopsy is virtual autopsy. We will be using CT for doing autopsy. Okay, imaging methods instead of cutting the body open. Okay, imaging methods for doing autopsy. So these are the main types of autopsy that we will be doing. Now coming to the autopsy techniques. Okay, so first is Rokitansky in situ, Vitchov and Mass gone en bloc, Letule one by one. Okay, so we will see what is what and we will come to the answer at last. Okay, so first Rokitansky, it is in situ. Okay, and it is preferred in infants and infected body. Okay, like any radiation or any infectious disease, all those cases we will be preferring this. Okay, and the main disadvantage here is that like thorough examination cannot be done, but organ relationship is maintained. Okay, organ relation maintained. Okay, so this is the first type. Then second, you have witchos. Here you will be taking one by one. Okay, you will be taking organs out. Okay, and this is mainly preferred. Okay, this is the most common. Okay, most commonly done. And the disadvantage is that the relationship is lost. Okay, the interrelationship is lost. The interrelationship is lost. Okay, but it will help in thorough examination. Okay, then thirdly, you will have letule. Okay, in letule, you will be doing en masse. Okay, that is from tongue to prostate. You will be taking them out, and here the advantage is that interrelationship maintained, but difficult to handle. Clear? Then finally you have gone. Okay, gone is en bloc. Okay, you will be taking organ blocks. Okay, like your thoracic block, abdominal block, like that you will be doing. And the main thing here is that it is easy to handle. Okay, that is the main advantage in here. Okay, so these are the main autopsy techniques that we will be doing, and the true matches here is that Rokitansky in situ is correct, so A is correct. Picture was en masse, no. Gone is en bloc, yes, right. Letule 1 by 1, no. So only A and C are correct. Okay, this is the correct answer for this. Next, we are going to the post-mortem changes. A post-mortem cooling graph is plotted. What is the ideal shape of this curve? The answer is this. Here, do you see? Okay, this is your sigma shape. Okay, this is your flipped edge. Okay, sigma shape curve, and this is the shape, that is how the algar mortis happen. Okay, post-mortem cooling is algar mortis. Okay, this is how it usually happens. Okay, that is cooling, and it happens by conduction, evaporation. Okay, by all these it will happen. Okay, so these are all changes that happens after the death. So first we will see what is death. Okay, so we have two types of death, that is somatic and molecular death. Okay, so the somatic death is your clinical death. Okay, and this molecular death is your cellular death. Okay, this is the difference between somatic and molecular death. There is one more condition, that is suspended animation. Okay, so this is a state of apparent death. Okay, this is a state of apparent death. Clear? But the patient is not actually died. Okay, the metabolism is really low that they will appear like that, but they are not actually dead. And this is usually seen under certain conditions, that is newborn, electrocution, drowning, yogi, hypothermia, and heat stroke. Okay, you can remember by the term needy hippo. Okay, needy hippo. Okay, so N for newborn, electrocution, drowning, yogis, hypothermia, and heat stroke. Okay, these are the conditions where people might look like dead, but they are not actually dead. Okay, that is suspended animation. Now, after the death happens, there will be certain changes that will be occurring, and we have arranged them into immediate, early and late changes. So, the immediate change that you will be seeing is loss of respiration, then loss of circulation, then loss of voluntary movement. Okay, so these are the immediate changes, okay, not your eye changes, not your hypostasis rigor. All these things, they will come under these. Okay, this early changes, okay, you will be getting eye changes. Okay, that is your Kevorkian sign. Kevorkian sign, okay, that is segmentation of the retinal vessels, okay, that is your Kevorkian sign. Then tachynoir, okay, you will be getting tachynoir. All those things you will be seeing in the eye. After that, you will be getting these alger mortis, rigor mortis, then liver mortis. So, alger mortis is what? It is cooling. Rigor mortis is stiffening. Liver mortis is nothing but your hypostasis, right? Now, we will see about alger mortis first. So, alger mortis, it is post-mortem cooling, okay. So, what is PM caloricity? So, PM caloricity is when the temperature of the body, remains increased, okay, remains increased after death, okay, that is post-mortem caloricity, and it is usually seen under conditions where there has been like pontine hemorrhage, okay, when the thermoregulatory mechanism is affected, pontine hemorrhage, heat stroke, okay, okay, and so these are the conditions, okay, pontine hemorrhage, heat stroke, okay. Here the thermoregulatory mechanism, it is affected, okay, and other conditions where you will be seeing is when there is increased production of heat after death, okay, when there is increased production of heat by some infections, okay, some bacterial infections, septicemia, okay, all those things you will be getting to see this. Or when there is increased muscular activity, okay, when there is increased muscular activity like tetanus, strychnine, okay, there also you will be seeing, okay, increased muscular activity. Under these conditions, the heat, the body heat, it will remain raised, okay. So, these are the conditions, and this is known as post-mortem caloricity, okay. And what is the best site to measure? It is subhepatic, okay, and rectum, okay. These are the best site to measure, okay, for the temperature. Clear? So, these are the important things about alger mortis and post-mortem caloricity. Now, next question. Chocolate color hypostasis, it is seen in all of the following except, okay. So, potassium chlorate, acetaniline, bromate, all these things you will be getting to see chocolate color. Only in antimony you will not be seeing chocolate color, okay. In antimony you will be seeing orange color, okay. And antimony, it also favors mummification. We saw in heavy metal, right? So, this is the color of hypostasis, okay. And there are certain conditions where you will be getting different hypostasis. We will see that. So, black you will be seeing in mummified bodies and opiates, okay. And after that, you will be seeing bluish green in case of hydrogen sulfide. Then violet in case of asphyxia, okay. This pink and red, these are the important thing, and chocolate. acetaniline, aniline bromates. Okay, you can use like this. Okay, dark brown or yellow, it is seen with phosphorus. Okay, these are the important hypostasis colors that you need to remember. Okay, and you can remember by the term band chocolate. Okay, band chocolate. Okay, B for bromate, A for acetaniline, aniline, then nitrobenzene nitrates. Apart from that, you have PC. Okay, band PC and chocolate. Okay, that is the mnemonic for this chocolate hypostasis. Now, how hypostasis occurs? Hypostasis is nothing but the gravity pooling. Okay, gravity pooling of blood inside the blood vessels. Okay, and the side that you will be seeing is mostly the dependent part. Okay, dependent part of the body. If it is a case of hanging, you will be seeing glove and stalk appearance. Okay, that is the dependent part, right? Okay, glove and stalk appearance. And in case of drowning, there will be no hypostasis because of the repeated movement. You will not getting to see any hypostasis. And also in case of anemia, you will not be able to identify any hypostasis. Okay, time of appearance, by 4 to 6 hours it will start to come, and by 8 hours maximum it will come completely and it will start to fix. Okay, between 8 to 12 hours it will fix. Okay, and these are like approximate value, not exact value. Okay, and the main thing you have to know is primary versus secondary hypostasis. So here what happens is that primary hypostasis is the one that comes first. Okay, and if the body is shifted, if the body is shifted before fixing, before fixing of hypostasis, you will get to see this secondary hypostasis. Okay, secondary hypostasis in another part. Okay, in another part. Okay, this is the main thing. So we can know whether the body has been shifted or not. Postmortemly, whether the body has been shifted or not, we can identify. Okay, so this is all about hypostasis. And in hypostasis, the thing you need to know is another name also. Okay, you have hypostasis, liver martus, suggelation, darkening of death, vibices. All these are another name for hypostasis. Clear? Now, rigor mortis we will be seeing. So, the first thing in rigor mortis that we have to know is the mechanism. It is due to depletion of ATP molecules. Okay, this is due to depletion of ATP molecules. And order of appearance, there are certain rules for that. So, first is your Niston's rule. Okay, first is the Niston's rule. Here what they say is that the appearance, it is in orderly. Okay, first it will come in the eyelids, then it will proceed to the facial muscle, then towards the neck, then upper limb, lower limb. Okay, in this order sequence it will be coming. That is the Niston's rule. Shapiro's rule is that it will come at once. Okay, at once all over the body it occurs, but the apparent what we are getting to see, okay, what is visible to us is that in this orderly manner. Okay, because Shapiro says that it is a biochemical process. Okay, so it occurs all at once. That is what his theory is. Okay, at once it occurs all over. Here he is saying it is coming in an order. Okay, so that is the two rules. And the time of appearance you can remember by the term 12. Okay, it comes in 12, stays for 12 and goes off in 12. Okay, everything in hours. Okay, it comes in 12 hours, stays for 12 hours and goes off in 12 hours. Okay, this is the order of appearance of rigor mortis. And this late appearance, it is seen in asphyxia. Okay, early appearance you can see in like tetanus, strychnine poisoning, any infections, all the condition where you get postmortem caloricity, all the conditions you will be getting to see this early appearance. And one more thing is that has been asked lot of times, the first site of rigor mortis, it is myocardium. Okay, and external site, okay, the first site externally that we will get to see is eyelids. Okay, these two we have to know. Okay, first site of rigor mortis. Clear? Done? Now next, there are certain conditions which simulate rigor. Okay, and we will see those conditions. So first and most important is your cadaveric spasm. It is also known as instantaneous rigor. Okay, it is also known as instantaneous rigor, and this is a pure antemortem phenomenon. Okay, means like nothing that happens post-mortem cannot simulate this. Okay, like the person, they will hold on to like some object. Okay, and it is very hard to break. Okay, and this is seen in violent death. Okay, it is seen in violent death. Okay, all these are important things at cadaveric spasm. And one more thing is that this cadaveric spasm, it is usually seen in single group of muscles. Okay, it is usually seen in single group of muscles, and it is mostly the voluntary group of muscles in the hand. Okay, this is the most common site that we will be seeing this cadaveric spasm. Apart from that, you can also see other conditions like heat stiffening. Okay, you will get to see heat stiffening, then cold stiffening, then gas stiffening. Okay, all these conditions, they simulate rigor. Okay, this heat stiffening, this is due to protein coagulation. Okay, protein coagulation. This cold stiffening is due to ice crystal formation. Okay, so these are the mechanism behind these condition, and the main condition that we need to remember is cadaveric spasm. Clear? Next, we are going to the late changes. So till now we saw the early changes, and now we are going to the late changes. So late changes is mainly you have decomposition. Okay, there are two processes. One is autolysis, another is decomposition. Okay, and there is one more process known as putrefaction. Okay, so the main difference here is that decomposition, it is a septic process. Okay, autolysis, it is an aseptic process. Okay, and the main organism and the enzyme involved in putrefaction is that Clostridium welchi. Okay, and the enzyme is lecithinase. Okay, that is the enzyme involved. So mainly in decomposition, you will be getting to see few changes. Okay, so first is your color change. You will be getting greenish discoloration. Okay, you will be getting greenish discoloration, and externally it is first in the RAF. Okay, in the right iliac fossa, it is the first site you will be getting to see. Okay, internally you will be getting to see in the intima of aorta. Okay, this is where you will be getting to see internally. Okay, and This greenish discoloration, you will also get something called marbling. Okay, around 36 hours you will get to see this marbling. This is due to bacterial action. Okay, bacterial action forming sulf meth hemoglobin, and they will have this road map appearance. Okay, it will have this road map appearance, and it is seen over upper chest and limbs. Okay, it is commonly seen over upper chest and the limbs. So these are the main color changes that you would be expecting. Next is your gas formation. Okay, so gas formation, what you will be getting to see is that, so first there will be post-mortem purging. Okay, post-mortem purging. So here what happens is that there will be accumulation of gas in the abdomen. Because of that, diaphragm would be pushed up. Okay, diaphragm would be pushed up, and there will be leakage of fluid. Okay, leakage or oozing of fluid from orifices. Okay, oral and nasal orifices. Okay, then secondly, you will be getting to see swelling of scrotum. Okay, and abdominal distension. Okay, all these things you will be getting to see because of the gas formation. And again, you will also get to see post-mortem blister formation. Okay, all those things are seen in this. And there are certain changes of decomposition. Okay, there are certain modification of putrefaction that we will be seeing. So first modification that we will be seeing here is this mummification. Okay, this is mummification, and this is adipocere formation. This is adipocere formation. So basically what happens here is that in mummification, when the dry and hot climate happens, you will get to see dehydration. Okay, dehydration of the tissues, and it goes from outside to internal organs. Okay, outside to internal organs it will be going. Okay, and you will be getting to see black color. Okay, black color, and these are the main things related to mummification. This saponification, this is mainly hydrolysis of fat. Okay, and it occurs in hot and humid climate. Okay, hot and humid climate you will be seeing this, and it starts from inside to outside. Okay, it starts from inside to outside, and in both of these you can estimate time since death, and facial and injury features are preserved. Okay, these both you will be having in these. Okay, and apart from that, in the saponification you will have a pungent odor. Okay, disagreeable odor. Clear? So these are the things that you will be mainly seeing in this modification, that is mummification and adipocere formation. Done. Next, there is one more thing known as Casper's dictum. It is basically 1:2:8. This gives the rate of decomposition. Okay, it is the rate of decomposition. It is air, water and earth. Okay, okay, air, water, earth. Okay, this is the rate of decomposition, that is Casper's dictum. Then next question, which of the following statement is correct with respect to the picture given below? Okay, this is a case of clot, especially a post-mortem clot. Okay, and this is a chicken fat clot. Why I am saying this, that here do you see two separate, okay, here above yellow, okay, this is your plasma, and this dark, this is your RBC settling down, okay. So this is a chicken fat clot, clear, this is a chicken fat clot. Now they are asking which is the correct option, okay. This forms when blood clots slowly. This type of clot protrude out of the lumen when cut the blood vessel. No. It is firmly adherent? No. And the clot, if fused, will give spurious result in toxicological analysis? Yes. So what happens is that here, when the blood clots slowly, you will be getting this, okay, that is true. Like this, normally this post-mortem clot we don't use, okay, it is generally avoided. But if nothing else is left, you can use this, okay. So better option here would be this, okay. So we will see about the antemortem and the post-mortem clot, okay. So post-mortem clot, mainly you have two types of clot, okay. So first is your chicken fat. I already told you, you will have two layers, okay. The two layers, upper plasma and lower RBC, okay. So this is the two layer, and this happens when blood clot slowly, okay. Second is your red currant jelly, okay. Second is your red currant jelly clot or black currant, okay. Red currant or black currant jelly clot. This happens when blood clots rapidly, okay. There will be no layers, okay. It will be single layer, okay. Single layer of clot, okay. Single dark layer of clot, okay. And the main difference between here is that it is dull and it protrudes out of lumen when cut, okay. So these are the main characteristics, and apart from that, you can also see they are firmly adherent, okay. They are firmly adherent to the blood vessels, okay. All the things that is opposite to this is post-mortem clot. You just remember one thing, and other thing you can write, okay. They are dull and they protrude out of the blood vessels when cut, and they are firmly adherent to the blood vessels. These are the main things related to post-mortem and the antemortem clot. Next, viscera in toxicology are stored in, okay, glycerin, rectified, formalin, saturated salt solution. So the answer is, like, in all the things we will be studying, okay. So the most commonly used is saturated salt solution, okay. So saturated salt solution is most commonly used. And rectified spirit, it is your ideal preservative, okay. It is ideal preservative. Now this saturated common salt, there is only one exception, that is your corrosives, okay. Except for that, you can use them in all others. And for rectified spirit, the exceptions are formic acid, acetic acid, paraldehyde, alcohol, kerosene, okay. And C for chloral hydrate, okay. Alcohol, chloral hydrate and kerosene, okay. So you can remember by the term face pack, okay. So these are the contraindication for using rectified spirit. Now for this no preservative, like if you are preserving hair, bone, or if you are going to analyze immediately, okay, all those things you don't need any preservative, clear. So these are the things related to preservation. Then finally, you can also use sodium fluoride, okay. This is mainly used in alcohol, then cyanide, okay. and we use them for preserving blood and vitreous. Okay, so these are the main where we will be using sodium fluoride as preservative. Clear? So we are done with the post-mortem. Now we are going to asphyxia. So first, Simon's hemorrhage, it is seen in electrocution, hanging, burns, throttling. The answer is hanging. Okay, so we will see about hanging, strangulation, throttling together. Okay, so it will be much easier if you see all the three of them together. It will be easier to remember also. So first, hanging. So facial congestion petechiae, it will be seen in the hanging. All the asphyxial death you will be seeing. In case of strangulation, it will be more prominent, and in throttling, it will be very much prominent. Okay, and dribbling of saliva, it is present in hanging, absent in both of these. And leaf faces sympathetic on side of, okay, on the side of knot. You will be seeing the ptosis and all. It is seen in hanging, not in throttling and strangulation. Okay, so externally what you will be seeing in the neck is that first is your ligature mark. Okay, this ligature mark, it will be oblique, incomplete and above thyroid. Okay, oblique, incomplete and above thyroid. Okay, in case of strangulation, it will be complete, transverse and below thyroid. Okay, this is how you will be seeing in strangulation. In case of throttling, what you will be seeing is mainly nail marks, okay, abrasions and contusions. Okay, like this picture you will be seeing in the throttling. Okay, these are the main features that you can see externally in the neck. And internally, when you dissect, in case of hanging, you will have pale and glistening subcutaneous tissue. Okay, in case of throttling, you will be having congested, okay, congested subcutaneous tissue. But in case of throttling, you will have frank hemorrhages, muscle tear and contusions. Okay, all these things you will be seeing in case of throttling. Now, the cartilage fracture, it will be mostly absent. Okay, in both of these, mostly absent. And in strangulation, if present, it is like mostly present only in the throttling only. Okay, thyroid and cricoid you will be seeing in strangulation, manual strangulation only. Okay, and apart from that, hyoid bone fracture. Okay, this is your outward compression fracture. Okay, here the cornua, it will be seen outside. Okay, this is seen in hanging and strangulation, not in throttling. Okay, this is your inward compression fracture. Okay, otherwise known as lateral compression fracture. Okay, here the cornua, it will be seen inside. This is seen only in strangulation. Okay, manual strangulation, that is throttling. Clear? And finally have the Amoset sign, that is horizontal tears in carotid intima. Okay, horizontal tear in carotid intima. It is in only in hanging, not in these two. Okay, then Simon's hemorrhage, it is hemorrhage in the vertebral body. Okay, it is seen in hanging, not in these two. Clear? So these are the main things that we need to know in case of hanging, strangulation and throttling. We'll take a short break. And the most important thing here is the manner of death. Okay, so hanging, it is mostly suicidal. Okay, it is mostly suicidal. You can also get accidental hanging, that is mostly seen with sexual perversions. Okay, sexual perversions you will be getting accidental. And there is one more, homicidal hanging, that is your lynching. Okay, mob lynching, that is your homicidal hanging. So these are the manners. Okay, strangulation, it is mostly homicidal, it is mostly homicidal, and accidental can also happen. And this accidental, it is known as Isodora Duncan syndrome. So here what happens is that, like the dupatta, it will get stuck in the wheel and accidental strangulation it will happen. That is your Isodora Duncan syndrome. And throttling, it is always homicidal. Okay, it is always homicidal. Clear? So these are the manners in hanging, throttling and strangulation. Now we have seen these mechanical asphyxia. Okay, till now we have seen hanging and strangulation. Okay, so there is one more term known as suffocation. Here what happens is that in both of the cases there will be obstruction of neck. Okay, there will be obstruction of neck structures, right? But in case of suffocation there will be asphyxia, mechanical asphyxia, but there will be no obliteration of neck structure. Okay, no obstruction of neck structures. Okay, that is your suffocation. Okay, so example is what? What are the examples you have? What are the examples? You have your gagging, choking. Okay, all those external pressure, everything would be absent, right? No external pressure here. Okay, all these are, okay. Next question. Body of asphyxial death was brought to mortuary. Signs of asphyxia are well developed and internal neck muscles were dissected to show lateral compression fracture. So this is a case of throttling. And the manner of death here. Okay, they are asking the manner of death, not the cause of death. So manner of death is homicide. That is the answer. And there are few things we need to know in hanging. That is the obliteration of neck structures. Okay, so there is, what are the mode of death in hanging? So first you have asphyxia, next you have blood vessel obstruction. Okay, that is your venous congestion. Okay, then vagal inhibition of heart. You have vagal inhibition of heart, and you have fracture, fracture of vertebra. Okay, that is usually seen in judicial hanging. Okay, so these are the things that you will be getting. Okay, clear? So these are the causes of death that you will be seeing in hanging. Now going to the next one. Which of the following statement is not correct regarding diatom? Okay, so diatom are aquatic unicellular algae, right? They are extracellular coat composed of magnesium, no. It is made of silica. So this is the correct answer for this question. An acid digestion technique, it is used to extract diatom, that is also right. Presence of diatom in femoral bone marrow does not confirm antemortem drowning, that is also correct. Okay, so first we will start the drowning and I will tell you further the diatom test. So first, types of drowning. So dry drowning, wet drowning, that is the main type that we have. Dry drowning, wet drowning. Okay. So what happens here is that, so wet drowning we all know. Okay. There's some like normal way of drowning. That is the normal way. Okay. Dry drowning, what happens is that you have laryngeal spasm. Okay. You will get laryngeal spasm. When there is sudden influx of water, there will be reflex spasm of the larynx and death occurs due to that. So there will be no water. Okay. No water entered the lung. Okay. This is one. And there is one more, that is immersion syndrome. Okay. Immersion syndrome, otherwise known as electrocution. Okay, otherwise known as electrocution. So what happens here is that when the body, okay, when the skin or any mucosa contacts the water, when it comes in touch with water, there will be reflex vagal inhibition. Okay, there will be reflex vagal inhibition, and here also there will be death and there will not be any water found in the lung. Okay, so here also no water in lung. Okay, so this is your two types of drowning, that is laryngeal spasm, then immersion syndrome or hydrocution. Okay, this is not electrocution, this is hydrocution. This is hydrocution. This is hydrocution. Clear? So these are the two types of drowning that we have to mainly know. Now, when drowning happens, wet drowning, you get either salt water or freshwater drowning. So in freshwater drowning, mainly there will be hemodilution. Okay, there will be hemodilution and there will be rupture of RBCs and hyperkalemia, which will result in heart failure and death. In case of seawater drowning, you will get pulmonary edema. Okay, and because of that, you will be getting death. Okay, so amongst these two, this freshwater is more dangerous. Okay, freshwater drowning is more dangerous than the seawater drowning. And the PM features that you will be seeing, main is that the first thing, tenacious froth, okay, in the mouth, in the larynx, in the respiratory pathway, everywhere you will be getting to see froth. It will keep on coming. Okay, it will keep on coming. Okay, and it will be hard to break. Okay, it will be hard to pop. Okay, these are the main thing. Then secondly, you will get to see cadaveric spasm. Okay, you will get to see cadaveric spasm. Okay, they will be holding on to these aquatic plants or some mud or something. Okay, and this is a surest sign. Okay, this is a surest sign of antemortem drowning. Now here, do you see the froth? This is also seen. And next surest sign is presence of foreign body. Okay, foreign body like aquatic plant or something in respiratory tract. In respiratory tract beyond tracheal bifurcation. Okay, preferably beyond tracheal bifurcation. And you will also get these edematous lung. Okay, you will also get edematous lung. Okay, these are the things that you will normally get to see in case of antemortem drowning. Now, the test that we usually do for drowning is your diatom test. Okay, this is your diatom test. Here, do you see this, all these are all your diatoms. Okay, these are all diatoms. and they have silica, okay, cell wall made of silica. Because of that, we will do acid digestion technique and still they will be remaining, okay. So now the fallacy in this diatom test is that, like, the main idea behind diatom test is that diatom is specific to water body, right? Diatom is specific to water body, and if the person was alive, okay, if the person was alive, then he must have inhaled that water, then diatom via that water entered the lungs, okay, diatom via the water will enter the lungs, and from that it will go to heart and to the peripheral circulation, right? That is the idea. Now what if that person, he is staying in that area and he has been drinking the water that has been contaminated with this diatom, and he is getting down in that water body? So here, even if the peripheral circulation is showing diatom, we cannot say the diatom is because of this, okay. So that is the one fallacy that you will be seeing in the diatom, okay. So that is why I ruled out that option, okay, done. So this is about the diatom, okay. Next we are entering thermal deaths, okay. So first question, Wisniewski spot are associated with? It is usually seen in hypothermia deaths, okay, clear. And hypothermia, when do you call a case as hypothermia? It is when the body temperature, okay, when the core temperature, it goes below 35 degrees Celsius, you will be calling it as a case of hypothermia. And by 32 degrees Celsius, the shivering will stop, okay. By 30 degrees Celsius, thermoregulation mechanism would be off, and finally by 26 degrees Celsius coma will occur, and if persists, death will occur, okay. So these are the important things related to hypothermia. And this J wave, otherwise known as Osborne wave, you will be seeing in case of hypothermia, okay. Now, in case of hypothermia, there are few things that you will be seeing postmortemly, okay. Postmortemly, you will be getting to see pink hypostasis, okay. You will be getting to see pink hypostasis, and also you will be seeing hide and die, hide and die syndrome. That is because of the extensive cold. They will undress, okay. They will undress. That is your paradoxical undressing, and they will go hide under whatever protection they could find. They will go hide under that and they will die. That is your hide and die syndrome and paradoxical undressing, okay. This is mainly due to false sense of heat, okay, false sense of heat due to the failure of the thermoregulation mechanism, okay. And these spots, these are known as your Wisniewski spot, okay, Wisniewski spot, okay. In these small pot, these are your basically gastric erosions, okay. These are seen in hypothermia death. Apart from that, you can also see fat necrosis of pancreas, okay. All these things are seen in case of hypothermia. And in case of hyperthermia, there are few conditions that you will be experiencing, okay. So first is heat syncope. Here what happens is that the person who is not accustomed, okay, when the person is not accustomed to heat, when they are suddenly exposed to that condition, there will be sudden peripheral vasodilatation, okay. There will be sudden peripheral vasodilatation, and because of that, there will be pooling of blood, okay, pooling of blood, and this will result in syncope, okay. This is your heat syncope. Okay, they are not accustomed to that heat, so there will be peripheral vasodilatation and pooling resulting in syncope. Okay, so this is the first thing. Now second thing, here heat cramps. Here what will happen is that there will be loss of salts. Okay, and there will be muscular cramps. Okay, there will be muscular cramps, also known as minus cramp. Okay, also known as minus cramp. Okay, clear? Now these heat exhaustion and heat stroke, they are kind of similar. Only difference is that here in exhaustion you will be seeing proper thermoregulation. Okay, thermoregulation is present. Okay, thermoregulation is present, and there will be loss of both water and salt, and neurological manifestation will occur and proceed to heat stroke. Okay, proceed to heat stroke if left untreated. Okay, if left untreated, it will proceed to heat stroke, and in heat stroke here there will be mainly absence of sweating. Okay, absence of sweating and failure. Okay, failure of thermoregulation. Clear? So these are the things that you will be mainly seeing. Okay, heat cramp, vasodilatation. Okay, heat cramp, you will be seeing loss of salt resulting in the cramp, and heat exhaustion and heat stroke. Heat exhaustion, there will be loss of both salt and water when left untreated. It will proceed to heat stroke. Okay, in case of heat stroke, there will be absence of sweating and failure of thermoregulation. Okay, these are the things that you will be seeing in hyperthermia. Now next, a person suffered from a burn injury, and examination, blisters and erythema were seen with line of demarcation extending below the region of burn as well. What is the type of burn the patient has suffered? So they are giving dry heat, moist heat, electrocution, chemical burn. The answer is moist heat, because normally in dry heat, so dry heat is what? So dry heat is so basically in dry heat what you will get is then flames. Okay, flames will cause the burn injury. In case of moist heat, here you will be getting hot liquids. Okay, hot liquids will cause burn injury, and these flames, they usually go up. So at an above the site, okay, at and above the site of contact, you will be seeing burns. Okay, but in case of hot liquids, they will go down. Okay, they will trickle down. So because of that, you will be getting to see at and below the site of contact. Okay, burns at and below the site of contact. Clear? So these are the important difference between this dry heat and the moist heat. Apart from that, you also get chemical burn, right? So dry heat we already saw it is caused by flames. Moist heat it is by hot liquids. Chemical burns it is by chemicals. And here the edges, okay, I already told you here it will be clearly demarcated. Here also it is clear, it is somewhat clear, okay, it is somewhat clear. And splashing and trickling it will be absent here, here it will be present. And vesicles it will be seen, like it is not seen here, here it will be seen, and here also in some cases it will be seen, okay. Then skin appearance, here it will be charring will be seen, here there will be soddening, okay, there will be soddening, there will be complete destruction, okay, you will be basically get ulceration, okay, there will be complete destruction. And red line will be seen here, here, here not seen. Then charring and singeing present, here absent. Ulceration absent, here it is present, okay. These are the main differences between dry heat, moist heat and chemical burns. Now, coming to the antemortem burns and the signs, okay. The first is the line of redness, okay. The first thing, line of redness along the edges, okay, you will be getting to see. Then blisters, they have more protein content and the base would be red in color, okay, and vital reaction would be present and carboxyhemoglobin level would be elevated, okay. These are all signs of antemortem burns, okay. And this soot deposition, this soot deposition in respiratory pathway, okay, especially trachea and below, that is also antemortem sign, okay. So that is also antemortem sign of burns, okay. These are the antemortem sign. Now we are going to see certain spurious sign, okay. These are mainly due to heat effect, okay. These are mainly due to heat effect. It does not say whether the burn happened antemortem or postmortem. These are mainly the heat effect, okay. So the first is your this one, this is what heat rupture, okay. This is your heat rupture. Do you see this split, okay, here, this split, this is your heat rupture, okay. This will simulate laceration, okay. This will simulate laceration and you can differentiate by, it can be differentiated by pale base, intact blood vessels and nerves, okay. All these things will be seen, okay. It can be easily differentiated. This is heat rupture. Now this is heat hematoma, okay. This is your heat hematoma and this is EDH confused, okay. It will be confused with EDH, okay. And you will get to see honeycomb appearance, okay. You will get to see honeycomb appearance and this is basically due to boiling of blood, okay. Boiling of blood in dural venous sinuses, okay. Boiling of blood in dural venous sinuses, clear. Now here, do you see this arrowheads and this arrow marks, okay. This arrowhead, this area, this is a true EDH, okay. While this arrow, these are heat hematoma. Do you see this homogeneous appearance and this honeycomb appearance? That is the main difference, okay. So this EDH and heat hematoma you can easily differentiate, and in heat hematoma you can see increased level, okay, increased level of carboxyhemoglobin, okay. That is also one differentiating point for heat hematoma. Now apart from that, you can also see heat fractures, okay. You can also see heat fractures, otherwise known as avenue fractures, okay, otherwise known as avenue fractures. And this is known as, this is due to pulling, okay, pulling of muscles and also heat effect. Okay, so these are the main thing that you will be seeing in this. Okay, so these are the spurious signs of heat and they are mainly due to heat formation. It is not sure whether it is antemortem or postmortem. We cannot differentiate a case by looking at these signs only. Okay, so the surest sign we already saw. Now going to the next question. Capital punishment can be given by all except. The answer is assistant session judge. Apart from that, all these people, okay, and Supreme Court, they all can give capital punishment. Only that the session judge, their punishment, it needs to be confirmed by the High Court. Okay, clear? And coming to the magistrate, okay, here we have to know the punishment. Okay, the years of punishment and the fine, amount of fine that they can give. So first assistant session judge, they can give up to 10. Okay, CJM is 7, first class is 3, second class is 1. Okay, you can remember by 7 3 1. Okay, CR7. Okay, after that you have the first, then you have the second. Okay, first will come like this. Okay, opposite to each other it will come. Okay, cross to it diagonally. Okay, like this you can remember 7 3 1. Then fine amount, it is any amount for CJM. Here it is 10 and 5. Okay, so again here you will get 10. Okay, here you are getting 5. Okay, so this one, it will come diagonally like this. Okay, CJM like this. Okay, like this it is coming diagonally. Clear? So these are the punishments. Next, there is one more term, presumption of survivorship and presumption of death. Okay, so first we will see the survivorship. So here what happens is that in presumption of survivorship, this is to see who survived longer, okay, or who would have died earlier, okay, who would have died earlier. So here what happens is that to distribute the property, like let's say two brothers are going in a cruise and the cruise went missing and they both died. Okay, now in that case what they will do is between the two they will try to decide who would have survived longer. So by age, by sex, by the medical condition, by using everything they will analyze, and it is usually the younger than the elder. So they will say the younger would have survived longer. Okay, so all the property it will go according to the will of the younger brother. Okay, so mainly for the distribution of property they used to use this presumption of survivorship. Now presumption of death, it is different. So what happens is that, like we'll take a case, there is one husband and wife and this husband he is missing for the past 2 years and the brother of the husband he is coming and saying that my brother has died, so I want all the property of my brother as per his will, like that he is saying. Now what happens is that, like up to 7 years, okay, up to 7 years, if the person is not heard of, like if there is no proof of life, if it is not present, if it is not given, then up to 7 years it is accepted. Beyond 7 years he will be presumed to have died. Okay, he will be presumed to have died. Now if the brother comes and alleges that his brother has died within 5 years, they will not accept. Okay, they will ask him for proof of death. Okay, but if the same brother, if he is coming after 7 years, now they will not ask any proof of death from him. Now they will ask for proof of life from his wife. Okay, so that is the difference. Okay, till 7 years no need for any proof of death, okay, or life, but after 7 years they have to provide some proof of life to make sure that he is living. Okay, so this is the presumption of death and presumption of survivorship. Clear? Next, a patient got admitted to hospital for malaria and the doctor started him on treatment for typhoid. Suddenly, an outbreak of COVID-19 breaks in the community and the patient dies as a result of that. The relatives, after knowing about the treatment regime followed by the doctor, files a case of negligence against him. In this, which of the following can be used as a defense by the doctor? Now, he is negligent, okay? He is negligent. Because for malaria, he was treating for typhoid. But finally, in the patient, he died of COVID-19, something that is totally unrelated. Okay. So, this totally unrelated act, okay, usually there was one negligent act and death usually happens because of that. But here, it did not happen. Death happened because of COVID. Okay. This event, this chain of event, it was broken by this new act. Okay. So, this is known as novus actus interveniens. Okay. Novus actus intervenient is new act breaking the normal chain of event. Okay. Normal chain of event. That is novus actus interveniens. Now, we will see at types of negligence. Okay. So, first is your civil negligence. And second is your criminal negligence. And when you call something as a negligence, you have to fulfill 4 criteria. Okay, there has to be absence of 4 D's. Okay, there should be duty and there should be dereliction of the duty. Okay, there should be dereliction of duty, and because of the direct causation, there has to be some damage. Okay, so all 4 Ds has to be there to call something as a case of negligence. Okay, and the civil negligence, here it will be small injury. Okay, small damage would be there. While in case of civil criminal negligence, there will be gross lack of care. Okay, and the damage would be more. Here it is usually patient versus doctor. Okay, here it is the state versus doctor. Okay, and the main thing here is this contributory negligence. Contributory negligence cannot be claimed. Contributory negligence cannot be claimed as defense. Okay, and it will be fought in a civil court. Here it will be done in a criminal court. Okay, these are the main differences between these two. Apart from that, you have patient negligence, corporate negligence and all. Okay. So, there are certain terms in negligence that we will see. So, first is vicarious liability. Means, let the master answer. Okay. So, not only for the own negligence but also negligence of workers. The doctor is responsible. Okay, the doctor is responsible. And borrowed servant doctrine is that even if that servant is not your own, okay, even if the servant is borrowed, you are responsible. Okay, you are responsible for their negligence. And finally, res ipsa loquitur, it is thing or fact speaks for itself. So, means like leaving a cotton swab or instrument inside the body, that thing. You don't need any expert evidence, okay? No need for expert evidence, okay? It is very, very apparent, okay? So, that is your res ipsa loquitur. And doctrine of common knowledge is the same thing, okay? It is the same thing. And what are the defenses as a doctor you can claim against negligence? So, first is medical misadventure or maloccurrence. Here what happens is that it is an unforeseen event, okay? Unforeseen, unheard of event. Like even after giving test dose, the antibiotic, it caused anaphylaxis, okay? That is something misadventure, okay? Small occurrence, but there has to be due care. Okay, it has to be there. You should have done everything properly with due care. Okay, so that is medical maloccurrence. Next is novus actus interveniens, we already saw. Then res judicata, like if a matter has already been decided, you cannot take the same case again. Okay, already decided, you cannot contest again. Okay, in the same court. That is res judicata. Indicata is within a period of 2 years. Within a period of 2 years, we have to take up the case. Okay, that is res indicata. And contributing negligence here, both the patient and doctor, both are negligent. Okay, that is contributory negligence. Then doctrine of calculated risk is like while doing thyroid surgery, even after careful consideration, after doing everything carefully, recurrent laryngeal nerve, it is getting injured. Okay, that is calculated risk. You have to do thyroidectomy because of cancer. Okay, because of this fear of injury, you don't avoid doing thyroidectomy. Okay, you are calculating the risk and you are doing that even after knowing that. Okay, so that is your doctrine of calculated risk. Okay, known after knowing the outcome. Okay, even after knowing outcome, you are doing for welfare. Okay, for greater good, you are doing for the greater good. Okay, that is calculated risk. And if the patient is not yours, if there was no duty, then you can use it as a defense. And the patient negligence, like here it was actually the patient who was negligent, he put cow dung over the wound, not you. Okay, so that patient negligence you can also claim as a defense. And there is one more thing that is known as product liability. Here it is the faulty product. Okay, the physical product, the medicine, something, the instrument, something that is faulty, not your fault the damage happened, it was because of the faulty instrument it happened. Okay, here you can claim that as a defense. And finally, the corporate defense, corporate negligence. So here what happens is that here it is not the doctor. Okay, it is the hospital, it is a corporate who is negligent. Okay, there will be lack of oxygen, there will be lack of essential medicines, all those things in the hospitals, that is corporate negligence. And there is another thing, composite negligence. Okay, composite negligence. Here two or more doctors would be negligent. Okay, two or more doctor would be negligent. Okay, this is your composite negligence. So these are the main things we need to know in case of negligence. Okay, clear? Next, a patient was referred to a doctor by a radiologist for a CT scan and the doctor was given money for the referral. What is this unethical act called? So this is known as dichotomy. Okay, this is professional misconduct. Okay, this is professional misconduct, otherwise known as ethical negligence. Okay, that there is no damage to the patient or something, but here the doctor is morally wrong. Okay, doctor is morally wrong. That is the professional misconduct. Okay, it does not come under professional negligence, it comes under professional misconduct. Here you have the A's like adultery, alcohol, association with unqualified person, advertising, abortion, and addiction. So these are the 6 A's. Okay, 6 A's of professional misconduct. Apart from that, you also have this bribery, convicted by court of law, dichotomy, issuing false certificate. All these things, they will come under professional misconduct. Okay, and there are few other things. Privileged communication. Okay, privileged communication. So normally whatever the patient is saying, it should be kept confidential. Okay, but in certain cases that confidentiality can be broken. That cases they are known as privileged communication. That is for the welfare of the society. Okay, welfare of the society. Like if you are seeing a colorblind person driving a school bus, you can go and complain. Okay, welfare of their own. Okay, welfare of their own. Like in case of negligent suit against the doctor, they can indulge the information about the patient. So under all these circumstances, privileged communication can be made. Okay, clear? Now next we are going to the identification. So the first thing, shovel shaped incision are seen in. Okay, shovel shaped, it is seen in mongoloids. Okay, in teeth there are certain characteristics that are specific to each race. Okay, so here what you are seeing, this is enamel pearl. Okay, enamel pearl. Okay, this, do you see this? This is your enamel pearl, and this is bull tooth. Okay, this is bull tooth. Here this root is wider, right? This is your bull tooth. Okay, and this is your shovel shaped incisor. Okay, all these three, they are seen in mongoloids. Okay, all these are seen in mongoloids. Mongoloids. Here this also mongoloids, and this thing here, this is Carabelli cusp. Okay, here this extra cusp, this is your Carabelli cusp, and this is seen in Caucasians. Okay, C for C, just remember it is seen in Caucasians. Okay, so these are the things that will be seen. And next for race we use cephalic index. Okay, it is maximum breadth by length, and you get 70 to 75, 75 to 80, then 80 to 85. That is long headed to short headed. Clear? So these are the things that you will be seeing here. And next, a pelvic bone was recovered from a forest. It was identified as belonging to a 30-year-old man. Which of the following is true regarding this pelvis? So pelvis, we mainly use them for sex identification. Okay, the pelvis bone, it is ideal for sex identification, and all the features, they are prominent for female. Okay, so the first thing you have to remember here, it is the pre-auricular sulcus. Okay, it is the pre-auricular sulcus. It is broad and deep in case of female. Just remember female for this. Okay, pelvis you remember only the female structures. For skull you remember only the male structures. That way you will not be confusing. Okay, and subpubic angle, it will be U. Okay, and then sciatic notch, it will be large, wide and shallow. Okay, here it will be shallow, and inlet would be circular. Everything in the pelvis will be favoring towards the baby. Okay, towards the parturition. Okay, so it will be ball shaped, and ischial tuberosity everted. Body of the pubis will be broad and square. Okay, then acetabulum small and anterolateral. Operator foramen small and triangular. Okay, so all these features you have to know, and this indices also they will be asking you. Sciatic notch index, it is given by width and depth. Okay, it is always width by depth. And Washburn index, also known as ischiopubic index, that is given by pubic by ischial length. Okay, all these features they will be seen prominently in case of female. Okay, so this is your pre-auricular sulcus. Here this is your pre-auricular sulcus. Okay, and here you can see this is the sciatic notch, it will be narrow. Here it will be wide. Okay, this is your sciatic notch. Okay, and here you can see V shaped, here it is U shaped, this pubic arch. Okay, and this pubic is triangular, here it is rectangular. Okay, so these are the main differences. Coming to the skull, here you just remember only the male characteristic. Okay, here everything will be large and heavier, and the glabella, supraorbital ridge, everything will be prominent except for the frontal. Okay, this frontal and parietal, it is prominent only in female. Okay, this thing you have to remember. Okay, then this digastric groove deep, corneals larger, everything will be larger in case of males, in case of skull. Okay, these things you need to remember. Then coming to the estimation of age. Okay, determine the age based upon the X-ray hand. Okay, here they have given the wrist. Okay, here first thing, whenever you get, just look at all the carpal bone, whether you are finding pisiform or not first. So here you can see the pisiform, it is over here. Okay, pisiform we are able to see. So the age has to be between 9 to 12. Okay, the next feature we have to look at is the base of metacarpal. It has not fused yet. Okay, it usually fuses by 16 years. So the answer is 9 to 16. Okay, that is the answer. So we will see what is the age. Okay, so for carpal you start with capital M. Okay, and go like this. Okay, like this you go. Okay, so 2, 3, then leave the pisiform, then again try 3 years. Okay, so lunate, scaphoid, and by 5 years everything will be coming, and this pisiform you will be coming by 9 to 12 years, and head of first metacarpal 16 years. Okay, so this is how you determine when wrist is given. And if they give you long bones like shoulder joint, elbow joint, hip joint, like that, you can use this. Okay, shoulder joint, the appearance, everything is appearance. Okay, here just remember head comes first, then greater, and then lesser. Okay, it is 1, 3, 5. Okay, elbow joint you have 5 mainly. So capitulum, C for child, 1. Trochlea, T for 10. Lateral, L will look like 11. So lateral 11. Medial is 5 to 7, and conjoined epiphysis between 12 to 14. Okay, for radius and ulna, this you can remember like this. Okay, lower and upper end, it will go in the shape of N. Okay, in the shape of N it will go 2, 5, 6 and 9, like that you can remember. Okay, next going to the hip joint, head great less. Okay, 1, 4, 14, there it was 1, 3, 5, here it is 1, 4, 14. Okay, and iliac crest 20, ischial tuberosity 22. Here it is U shaped instead of N. Okay, 0, 1, 1, 4, like same to this. Okay, 1, 4, 1, 4, here also 0, 1, 1, 4, like this you can remember. Then for fusion, remember like this, a person, he is lying on the beach holding a glass. Okay, so 16, 17, 18, 19. Okay, here elbow will come. Then hip and ankle at 17. Then shoulder and knee at 18, wrist at 9. Okay, this is the approximate age where the fusion happens. Okay, so these are the fusion. Okay, appearance we saw. Now this is fusion, right? So next question. A 10-year-old child will have how many teeth? They are asking. 8 permanent, 16 temporary. So normally in case of like mixed dentation, okay, in case of mixed dentation, that is between 6 to 11 years of age, you can identify the number by using this formula, age in years minus 5 into 4. So here you will be getting 20. Okay, you will be getting 20 permanent teeth. Okay, this is the formula for permanent teeth. Okay, so this is the correct answer for this. Okay, this is the correct answer for this. And from teeth you can determine age first by eruption. Okay, primary teeth, the eruption, it comes, you can remember that by South Indian idli mother can make. Okay, so south is down. Okay, so it is lower incisor. Okay, that is central, always central comes first. Okay, then upper central incisor, then upper lateral incisor, then again lower lateral incisor. Okay, it will go like this, 6, 7, 8, 9. Okay, everything in months. Okay, okay, so we are done with incisor, 2 incisor over. Then M for molar. M1. Okay, C for canine, then molar 2. Okay, here we are done with 9, so here it will be 12, 18, 24. Okay, everything in months. This is your primary. Okay, central comes first and it is a lower incisor that comes first. Okay, this is for primary. Then for secondary, I mean permanent teeth, you can remember by mama is in pain, papa can make medicine. Okay, this is how you can remember. Okay, so here it is very easy. Molar 1, then incisor, it is the central, and then the lateral. Okay, central and then the lateral. Then you have the premolar 1, premolar 2, canine, molar 2, molar 3, 6, 7, 8, 9, 10, 11, 12. This is variable. Between 20 to 25, it is variable. So everything is in years. Okay, so these are the permanent teeth eruption that we will be seeing. Okay, age of mixed dentition we already saw, it is between 6 to 11 years. And super added teeth are, that is, they don't have any precursors, they come as an addition. Okay, those are your molars. Okay, 3 molars. Okay, M1, 2 and 3. And successional teeth, they have precursors, all others are your successional teeth. Okay, and other methods that we use in dentition for age estimation is, first is stacks. Here you can determine the age from the height and weight. Okay, and in boys you will look for the neonatal lines, incremental neonatal lines. Okay, then in Miles method, what you will be looking at the molar, wear and tear. Laminate, you will be looking at the gum regression. Okay, so these are the main thing that you will be doing. Then Gustafsson is, it is done in adults where eruption is complete. Okay, eruption is completed, and you can remember by the term A P S R T C. A for attrition, P for paradentosis, S for secondary dentin deposition, R for root resorption, T for transparency, T for transparency of root, and C for cementum apposition. Okay, C for cementum apposition. And here this is the most reliable. This is the most reliable, and this is the second most reliable. Okay, this is the second most reliable. So these are the things that you normally use. Okay, so next we are going to IPCs. Okay, murder. Here we will be mainly seeing all the IPCs. Okay, so now you need not read IPC, you only read BNS. Okay, you only read BNS. Okay, so BNS we are giving. So culpable homicide is 100. Okay, then murder is 101, and culpable homicide by causing death, this is not needed. Then punishment of murder is 103, and this punishment for culpable homicide is 105. So 100, 101, then leave 1, that is 103, then leave 1 again, 105. Okay, and negligence, it is given separate 106. Okay, then attempt to murder is 109. So these sections are very important. Next, rape we already saw all these. And this age for criminal responsibility, this is also important. It is 7 years, it is given under 20. So like it is in sequence. Okay, so 21, it is 7 to 12. And mentally ill, Meg-Norton rule, it is given in section 22. Okay, intoxicated against will, not criminally responsible, 23. Okay, then consent on behalf of minors, it is 27. And consent not required in emergency, it is 30. Okay, and Dowry death, here it is given in a separate section 80. There it used to be 304, right? Here it is 80. And abortion, criminal abortion, they have given 88, 89, 90, 91. Okay, so first is miscarriage, plain, here without consent, okay, without consent, and here it is death is caused, okay. Then it is done with intent to prevent child being born, okay. So the decapitation or something when they are doing that, okay. So these section you need to remember. First with consent, second without consent, third is death. These three you need to mainly remember: 88, 89, 90, okay. And the sexual assault, we already saw harassment. 77 is voyeurism, 78 is stalking. Then perjury, giving false evidence, it is 227, okay. And then punishment is 229, and fabricating false evidence, here it is 228. Everything is given in sequence, okay. Then hurt, 114, okay. 15 is voluntarily causing hurt, 16 is grievous hurt, okay. So here also it is given. And this using grievous, causing grievous hurt by use of acid, this vitriolage, here it is given and section 124 BNS, okay. And BNSS, that is your CRPC replacement. You have police inquest 194, 196 magistrate inquest. And this section 51, it is for examination of accused without consent, okay. Here there it used to be 54 CRPC, here it is given like this, okay. Clear? Now this battered baby syndrome is identified by stab wound, gunshot wound, bruises of different age, none of the above. The answer is bruises of different age, okay. So whenever a case of battered baby comes to you, there will be few features that typically you will be getting to see. History not matching wound, okay. History not matching the wound, and the wound will be of different ages, okay. Multiple wounds in multiple ages you will be getting. Then you will be getting to see this tear of frenulum, okay. And this bucket handle tear, okay. Bucket handle tear also you will be seeing. Apart from that, you will be seeing pearl string appearance, string of pearl appearance in the paravertebral gutter, okay, in the paravertebral gutter. And butterfly bruises, okay, due to pinching you will be getting butterfly shaped bruises. All these things you will be typically seeing in battered baby syndrome, okay. In shaken baby you will be getting intraocular hemorrhages, okay, intraocular hemorrhages and intracranial hemorrhages also. SCH you will be getting, okay. So Munchausen syndrome by proxy, here what happens is that for getting attention, the caretaker, usually the mother, the parent, they will harm the child, okay. The parent will harm the child, and when they are separated, the child will get better, okay. This is the usual sign, okay. This is your Munchausen by proxy. Then finally SIDS. This is a diagnosis of exclusion. When you get a infant death and you are not finding out any cause after doing all sort of investigation, you will call it as a SIDS, okay. It is mainly a diagnosis of exclusion. Apart from that, in case of a newborn, you will be doing autopsy to find out whether the case is live born, dead born or stillborn, okay. So dead born you can say when there is maceration or rigor mortis or mummification or adipocere. If any of these is present, we can call it as a dead born, okay. If it is not there, it can be either live born or stillborn. In live born, to conclude it as a live born, you will look for signs of respiration, okay. And one of the surest live birth sign is presence of milk. Okay, it is presence of milk in the stomach. Okay, and in the test for Libon, the main test that we have to know is Raygaard's. Okay, it is the Raygaard's test. It will look for the specific gravity of lung. Okay, it is also known as hydrostatic test. If the lung has taken breath, okay, if it is a live baby, lung respiration has been taken, the lungs will float. Okay, that is the thing. And there are certain fallacies to that, like in case of putrefaction, even dead baby lung floats. Okay, and if there is feeble respiration or if there is atelectasis, in such cases even Libon lung sinks. Okay, so these are the main things, the must know things that you have to remember in case of forensic. Okay, this is kind of a rapid revision for forensic, and with this we are coming to the end of this session. Okay, so here we have seen a lot of things. You will be having a lot of things to cover in the few days to come. Don't look at the mountain of things that you have to do. Just focus on the small things. Just look at the particular stair that you are look at. Okay, don't focus on the whole building. Okay, take one step at a time and you will be able to finish completely, and you will get a good seat and mark in the NEET PG exams. Thank you.